Good morning and welcome to the 2020 World FTD Marathon. My name's Tracy Wardle. As Chair of World FTD United, it's my great pleasure to welcome you all and to kick off the first leg of the FTD Marathon, a journey which is going to take us right around the globe over the next 24 hours. World FTD United is an international group. Our mission is to connect organisations and health professionals who provide support to those affected by frontotemporal dementia. An important goal for World FTD United is to raise awareness of the disease. So since 2016, we have organised World FTD Awareness Week. We decided that 2020 warranted something special. We've all faced particular challenges as the world has tried to deal with the COVID-19 pandemic. But for many of you, these have been particularly difficult times. Caring for someone with FTD at home in lockdown can be tough. Equally, not being able to visit your loved one in residential care can be distressing. So in response to all the challenges that have been thrown us this year, the 2020 World FTD Marathon was born. It's been absolutely wonderful to see members of the FTD community from around the globe rise to the challenge. We've had researchers, clinicians, scientists, carers, all putting up their hands to contribute to the event, to make the marathon something special and I think quite unique. The Australian leg is going to run for the next 4.5 hours. We're going to hear from a range of specialists, from neuropsychiatry at the Royal Melbourne Hospital and from Frontier Brain and Mind Centre at the University of Sydney. All our presenters have fabulous knowledge and experience of FTD, which they're hoping to share with you today. We're also going to be really privileged and hear from some people who have been caring for those with FTD. The Australian leg will conclude at around 2:30 this afternoon, but the marathon won't be over. When it is 10 a.m. Central European Time, which is 6 p.m. Australian Eastern Standard Time, the European and UK leg will begin. It will run for 6 hours, at which time the North, South and Central American leg will take over. We really hope that you will join us during this journey, that you will tune in to as many presentations as you can manage. It's not too late to register for the other two legs. Just go to World FTD United. You'll find the links to register. You'll also find a detailed program. You can join in, you can leave us and come back. We'll still be here. We're going to do whatever we possibly can to get the technology to run as smoothly as possible, but please forgive any glitches or hiccups. Importantly, if you lose your connection to the webinar, just log back in using your original link. Now, Professor Olivier Piguet, clinical neuropsychologist and director of Frontier at the University of Sydney, is going to take over as chair for the first part of this Australian leg. Olivier is also going to present our first talk, What is FTD? Before he takes over the reins, we're going to have a few words from Dr. Rosa Radamakers, President of the International Society for Frontotemporal Dementia.
Good morning. My name is Rosa Radamakers, and I'm the current President of the International Society for Frontotemporal Dementia. And it's also my pleasure to welcome you to this event, which is really meant to raise awareness of frontotemporal dementia. And I was so excited to hear from Tracy that there was such an excitement and overwhelming enthusiasm for people to participate in this event. I think it shows that frontotemporal dementia is an important disease that affects a lot of families, and it really shows that it deserves our attention. ISFTD, for those of you who don't know us, we're a scientific organization that was founded in 2011, and it is our aim to bring together researchers from various disciplines and backgrounds to share our knowledge on FTD and to fight this disease together. We organize a number of things, including a biannual meeting. Unfortunately, our in-person meeting, which was meant to be held later this month, had to be canceled. But we're now going to have a virtual meeting that's going to take place March 4th and 5th of 2021. And we hope to also meet in person again in the fall of 2022 in France. Another thing that our society just did was editing a book. It's going to be the first book from the society, and it's going to be published by Springer in the beginning of November. It's written by experts in the fields, and it really is a sort of a summary of the current state of our fields, and also a collective vision towards the future, and where we think that the progress is going. Frontotemporal dementia is the second most common young onset form of dementia, yet it is so often overlooked, and it still takes much too long for most patients to receive an accurate diagnosis. It's a very difficult disease. People often have personality changes that happen early in the disease, which is devastating not just for the patient, but also for their loved ones. So I think it's very important that we unite to fight FTD. And at ISFTD, we want the caregivers and the patients to know that there's an ever-growing number of really motivated scientists, including very young scientists, who want to learn more about frontotemporal dementia, who want to learn how to better diagnose patients, how to understand the mechanisms that underlie this disease, and eventually want to help to develop and find treatments. So I hope you're going to see a glimpse of all this excitement that's going on in the field in the talks later today, and I wish you a great meeting.
Good morning. Thank you for the introduction. And it's my great pleasure to be the first person to talk and to kick off this first World FTD Marathon. And I would like to, first of all, to thank World FTD United for this wonderful initiative and this great idea. Just a reminder, if you have questions, you can use the chat box to ask your question, or question box, and these questions will be curated. And at the end of each talk, there'll be opportunities for the presenters to answer some of these questions. We won't be able to answer all of your questions, but we'll endeavor to answer some of these questions in real time, and otherwise we'll create a document that answers the most commonly asked questions. As Tracy and Rosa have indicated, frontotemporal dementia is a challenging disease to diagnose and investigate. There are multiple clinical presentations and with multiple brain pathologies involved, and often there's confusion with other brain disorders. Many of these aspects will be discussed here today by clinicians, researchers, scientists, carers. And I hope you will enjoy this presentation today that will cover many of these aspects of frontotemporal dementia. Now, my task today is to provide a very broad and brief outline on frontotemporal dementia. And this outline will set the scene for the future presentations in this morning's session. As been alluded to, frontotemporal dementia is one form of dementia, and a less common form of dementia. And overall, it is estimated that frontotemporal dementia accounts for about 15% of all cases of dementia in overall. However, and why the name frontotemporal dementia? Because it's a progressive atrophy of the frontal and temporal brain regions. And here on these slides on the right-hand side, you see a healthy brain. And you can appreciate the change looking at the brain on the left-hand side and highlighting with the circles here the part of the brain that is showing predominantly shrinkage in these brain regions, frontal and temporal lobe regions. Why these regions? Well, still not clear, but why these brain regions are more vulnerable to frontotemporal dementia. And this is one of the challenges that many people are investigating. Now, as I said, it's a as I said, it's a less common form of dementia, but if you look at the people aged before the age of 65 years, or called younger onset dementia, it's the second most common form of dementia after Alzheimer's disease. And in general, the typical age of onset of frontotemporal dementia is between the age of 50 and 70 years. And certainly about 60% of people will have an onset before the age of 65 years. Now, the survival rate is one of the questions that many families ask us. How long will this disease last? And this is one of the difficult questions that we still don't have an answer to, because the survival is very variable, and it depends on the clinical presentation, so which symptoms the person will present with, and also whether it's linked to other forms of additional symptoms like motor problems, and also whether there's a genetic involvement or not. And again, so these issues will be covered later this morning. In Australia, it's estimated that about 20,000 people are living with frontotemporal dementia, and it's probably an underestimate because of the difficulty diagnosing this disease. Importantly, the cost of looking after someone with frontotemporal dementia is enormous, and it's estimated to be about $125,000 a year per person in direct and indirect costs, which include loss of income and so on, and the fact that you will have a carer or family members who will need to take time to look after the person affected by the disease. Now, in the literature, three main presentations of frontotemporal dementia are described. There's a behavioral variant, frontotemporal dementia, which is the most common one, and with individuals presenting with marked changes in behavior and personality. What we see is disinhibited behavior or marked apathy, difficulty related to other people's emotions, and understanding emotional states of family members, difficulty understanding contextual social cues, and also marked accompanied by the loss of insight. So often people have difficulty understanding that they are experiencing these changes in their behavior. In addition to the behavioral variant, we have two language variants of frontotemporal dementia. The first one is called semantic dementia, where people with this form of frontotemporal dementia experience a progressive loss of knowledge about the world. And so it presents as a difficult, generally as a complaint by the person that they can hear word, they can read word, but they don't understand the meaning of these words anymore. And so it's an increasing difficulty to understand language, but it goes beyond language because it's really a broad, progressive loss of understanding of what things are. And then it impacts not just language, but also difficulty recognizing objects, faces, and also emotion. The other language presentations is called progressive non-phonophasia, which is a bit the other side of the coin from semantic dementia, in that in these people, the language is preserved, comprehension is preserved, but there's a marked difficulty with expressive language. And often there's distorted speech, difficulty making sounds that to put words together, and it's effortful and often accompanied by a loss of grammar. Now, with disease progression, what we see is a progressive overlap between these syndromes because, unfortunately, we are dealing with progressive brain disorders. So with pathology that continues to accumulate across the brain, we see additional features emerging over time. Now, what we see is that also research has shown that frontotemporal dementia is part of a spectrum of disorders. So in addition to these clinical presentations, it's also associated clinically and pathologically with other disorders that you might have heard of, such as corticobasal degeneration, progressive supranuclear palsy, or even motor neuron disease. So clinically, we have a difficulty in that there's broad descriptions of these syndromes that are presented on the left-hand side in these nice little hexagons, but the clinical reality is more like this, where you have a person who will present a mix of features and evolution over time, which makes the life of the clinician slightly difficult. Now, clinically, it's complex. Pathologically, it's also complex. So what is happening in the brain? And overall, we know that 3 categories of pathology, and 2 of these are presented on the left-hand side of this slide, tau and TDP, and then in the little green box at the bottom, FUS, account for about 90% of the pathologies that we find in the brain of people diagnosed with frontotemporal dementia. Now, the question is, how do the clinical presentations relate to what is happening in the brain? And that's where another difficulty arises. If we take the language presentation, so semantic dementia and progressive non-fluent aphasia, the story is quite simple. Semantic dementia in general is associated with TDP43 in the brain, and a few cases will be associated with tau deposition in the brain. If we look at the progressive non-fluent aphasia, it's the other way around. Cases with progressive non-fluent aphasia tend to have tau deposition in the brain, and a few will show TDP in the brain. Now, if we look at the presentations with additional motor components, such as motor neuron disease, again, there's a clear differentiations or clear demarcations of what the expected pathology will be in the brain, TDP43 and FUS. Whereas the other types, corticobasal degeneration and progressive supranuclear palsy, are primarily associated with tau in the brain. Now, the most difficulty is with the behavioral variant frontotemporal dementia, which is the most common form of frontotemporal dementia. And unfortunately for this presentation, what we have is this. So the clinical presentation is unable to tell us anything at this point in time of what is happening in the brain of the person with this clinical diagnosis. So to look at this in another way is, and when you put all this together, one can appreciate the complexity and the challenges in relating clinical presentations and pathological changes. So to put that in a slightly different context, or another way is to, with frontotemporal dementia, is that we have a pathology that can lead to multiple symptoms, but at the same time also a symptom or clinical presentation that is related to multiple pathologies. So again, you can appreciate the complexity and difficulties in tackling this disease. So there are a number of issues working current in frontotemporal dementia, and as I've alluded to, the main one is that the diagnosis remains very challenging. There are multiple presentations, multiple pathologies, and continuing evolution over time with changing features with the disease progression. Often there's also confusion with psychiatric disorders, and we'll hear more about that later on this morning, and also trying to understand the genetic contribution to these disorders. And the next speaker will discuss this in greater detail. Now, when families come to see us, often there are 3 questions that they ask. The first one is, what is happening to me? So the issue of diagnosis. The next one is, what will happen to me? So the question of prognosis and disease progression. And this is where one of the main challenges remain, is that predicting the disease progression remains extremely difficult in this disorder. And the third question is around treatment and drugs. And again, we are still, there's still a lot of work to be done in that area, because there's no cure or disease-modifying treatments. And at the moment, treatments are more around symptomatology or addressing clinical features such as behavioral changes or language difficulties. As you can appreciate, being a younger onset dementia, there's a great social and financial impact on the person with the disease, but also the family and their friends and their social network, and associated with the high burden of care on families. Despite these challenges, we have made a significant improvement in the past 10 to 15 years in our understanding of this disease, with the efforts of a large community of clinicians and researchers around the world. We are certainly able to diagnose FTD earlier and understand the progression of the disease better, although more work is still needed. Certainly, cure is still eluding us, but I believe that we're getting closer to this goal because of this international effort. Now, I'll finish that off here. Again, this is a broad overview of what frontotemporal dementia is. But I wanted to take this opportunity to thank the whole team here at Frontier in Sydney, at the Sydney University, and all our collaborators in Sydney, in Australia, and around the world, because it is really a group effort, and it is through collaborations that we'll be able to make further progress and understanding in this disease. And finally, I would like to thank all the families that have generously participated in our research projects over the years. Thank you.
Thanks, Olivier. That was a really good talk. So we have a question from Peggy, who has asked, can we tell how aware of their surroundings people are when they're in the severe stages of FTD?
It's a good question, a difficult question. With the progression of the disease, and even often in the early stages, there's a progressive loss of insight. So the capacity to self-reflect and understand what is happening to us, what is happening around the world, and how our behavior and actions impact on other people around us. And unfortunately, this is one of the main features, particularly in the behavioral variant frontotemporal dementia. So I think that there's a greater difficulty in relating to the world in general. However, I think there are different ways to communicate with a person with dementia in the more advanced stages of the disease. And that's where communicating through maybe less language, because there are some problems with understanding understanding words and expressing speech, but through touch, through music, through actions, there's ways to communicate. I think also something to remember is that these things varies, so they fluctuate during the day and from day to day. So we all have good days and bad days, and it's the same for a person with dementia. So trying to be aware, more mindful of these moments where the person might seem more aware, awake, I think is also important.
Thanks, Olivier. That's all we had in terms of questions. Just a reminder to everyone in the audience to direct your questions to the question box, and we will answer them as best as possible and then ask the speaker at the end. Thank you.
All right, so our next speaker is Professor Clement Lloyd, who will talk about genetics in frontotemporal dementia. And it's my great pleasure to introduce Clement. And I've known Clement for nearly 20 years. And Clement is a cognitive neurologist with research interest in molecular genetics. He's been working in the field of frontotemporal dementia as well as Huntington's disease and familial Alzheimer's disease. He trained in Sydney, in London, and has been back in Sydney since 2003. He works at the University of Sydney and also at Westmead Hospital, where he is in charge of the Huntington's disease program, and also collaborations and work at the Garvan Institute of Medical Research. So it's my pleasure to welcome Clement for this next presentation.
Thanks very much, Olivier, for the lovely summary and for the introduction. And thank you also to Wendy for the invitation to join you today, as well as for hosting this. As we begin, I just want to acknowledge the traditional owners of the country on which we meet today, the Gadigal people, to recognize their continuing connection with the land, waters, and culture, as well as paying our respect to the elders past, present, and emerging. Great. Thanks, Olivier. Fantastic. Good morning and welcome everyone to the second talk for the 2020 World FTD Marathon. And COVID certainly has changed how things work, and I can't see you, but I presume you can see me, and welcome. For the next 20 minutes or so, I would like to chat a little bit about the genetics of FTD. Since 1998, mistakes in the number of genes have been identified as the cause for FTD. And in fact, Rosa Radermakers, that you heard from earlier today, has been one of the instrumental scientists in unraveling the genetics of FTD. The genetics of FTD had taken us to some new places scientifically, but clinically and on practical terms, it also means that an offspring of someone carrying one of these genetic mistakes would have a high or 50% chance of developing FTD also. So when I chat with patients that I see and their families, one of the natural questions would be, my aunt has FTD, what does it mean for me? I can't see you, but I presume a number of you will have a similar question. Unfortunately, for most people with a family history of FTD, they don't actually have one of these single gene forms of FTD, but the question is how we separate out the single gene forms from usual or ordinary family history of FTD. And to do that, I would like to introduce you to some of the basic concepts in modern genetics, talk about single gene diseases, then broaden our discussion to genetically complex diseases and show you how they sort of work out in family trees, and then bring the two together and look at family history and FTD, and then we can conclude with a few remarks and questions. In the middle of that, I'll have a quiz, so you might have to pay attention. Okay, introduction. So our bodies are made out of cells. in fact, about 37 trillion of them. But within each cell, there's genetic material. The genetic material, if you like, is the instruction booklet for each cell. So if there's a mistake in it, then we won't be able to, the cells won't be able to function normally. I don't know whether you can see the pointer, but here we go. Within each cell, there's genetic material packaged in chromosomes, but as many of you would have heard, then they are stored in this information package is called DNA. Within DNAs of our DNA, that we all have 25,000 genes each, and these genes are encoded in information packages called nucleotides. So we all have 3 trillion nucleotides in our genome and 25,000 genes. Unfortunately, in single gene diseases, the mistake in one of these 25,000 genes, or even mistake in one of those 3 billion nucleotides, that's enough to cause disease. And that happens to certain forms of FTD or frontotemporal dementia. So how does that work out in terms of families? So we actually do have 2 copies of each gene. In the single gene form of familial FTD, a mistake in one of the 2 copies of the gene is sufficient to cause disease, and that's called autosomal dominant. Here I've got a diagram. I'm showing you how the genetic mistake may flow in the family. In FTD, the inheritance is not sex or gender specific, so this diagram could equally apply to someone where the mother rather than the father has got an illness. So as you can see here, the mother doesn't have FTD, and she's got 2 copies of that single gene associated with FTD, and both of them have no mistakes in them or normal. In the father who has FTD, he also had 2 copies of the genes, but one of them has a mistake in it with a big D, and one of them doesn't have the mistake in it. As each child is formed, that child or offspring would then inherit one of the 2 copies of the genes from his or her mother. And in this case, because both of them were normal, that would be a normal copy of the gene. However, when they inherited that 1 copy of the gene from the father, then you've got 1 in 2 or 50-50 chance of inheriting the genetic version with a mistake in it. So this means that every child of someone with a single gene form of FTD would have a 20 or 50% or 1 in 2 chance of inheriting it. Many of you might be interested in family histories and might have seen our family trees before, just briefly going through what they include. So a square symbol represents males, circular females, horizontal line means partnering, vertical lines means offspring. So here you've got grandfather, father, and grandchildren down here. The family trees for families with autosomal dominant or single gene forms of FTD typically involve family members from many generations. This indicates a strong family history. As you can see here, when a person's symbol is colored in, that means that person has the particular disease. So in the single gene form of FTD, typically you would see multiple generations all affected with FTD, and there's no break because that mistaken gene is passed from one generation to the other. And because each offspring would have a 1 in 2 or 50-50 chance of inheriting it, there are also multiple people affected in each generation. As you can see here, the mistaken copy of the gene has been passed from the grandfather to the father, and then to the next generation. Amongst people who didn't inherit the mistake from the father, none of these persons' offspring would have this particular form of FTD. However, for the persons inherited it, such as this daughter here, her offspring can also have FTD. Okay, so that's the first section. We've talked about genetics in general and single gene diseases. Now I would like to introduce another concept, which is a genetically complex disease. And as we were talking about the single gene diseases, you might think, oh, actually, I do know, there's certain family histories in my family, but not everyone would get it. For instance, my grandfather might have had a heart attack, but my father didn't get it, but my brother had a heart attack. And that's an example of genetically complex disease. In other words, a family history does not necessarily imply that there's a single gene disease in the family. So on the left is a diagram schematic illustrating what we talked about before, when you've got a mistake in a single gene that could cause a disease. And single gene forms of FTD is one example, Huntington disease is another example. However, more commonly, we will have genetically complex diseases where there is a family history, but the causation is not so direct. In fact, that's due to variations in multiple genes, and these are normal variations that increase your susceptibility, but not necessarily cause it. And there will be environmental factors, and that all contribute to a family history of a certain disease. So examples here would be diabetes, stroke, or heart attacks, which that may run in the family, but it doesn't go in every generation, and that's not that frequent. So going back to our idea of what it looks like in the family tree, you would see this family tree where there's someone with FTD here, but her older sister developed some sort of dementia in her late 70s. So that's one example where there is some familial predisposition. There's a family history, but it doesn't have that multi-generation transmission that you see in the other family trees, and it looks a lot more sparse, and that's what it looks like in a family tree when you've got a genetically complex disease. Okay, so we're halfway through our talk now, and I think it's time to have a bit of a quiz. So Wendy, I think you've been able to open a poll for everyone to vote. Fantastic. Now I've got a family tree here, and I'll give everyone maybe 30 seconds to have a look and see whether you think this is a single gene family tree or complex family tree. We're getting the votes coming in, which is fantastic. We've got 28% of people voted so far. I'm starting to sound like one of those tele salespeople. You still got time, you still got time, you still got time. So I'll give you another 10, 15 seconds. Okay, so we might close the poll now. Thanks very much, Wendy, and I'll try to, we won't share the result, I can just read it out. So in this poll, 60% of people thought that this is a single gene family, and 40% thought there's a complex genetic family history. So yeah, so the majority is right. In this situation, multiple generations were affected by FTD, even though there aren't that many in each generation, but it's clearly passed from one generation to the next, and there are multiple family members. It hasn't skipped a generation, and it's gone over 1, 2, 3, 4, 5 generations. So it's a tricky one, but well done for getting that right. Okay, I'm going to put up another quiz now. What about this one? I think my slide might have. I have to click on something here. Yeah, fantastic. So what about this second one? And Wendy, could you put on a new poll?
Yeah, I'm just having a few troubles with that, Clement. So you might actually have to just ask the audience, or even if they put it in the chat. So yeah.
Okay. So second one, does it look like a single gene or complex family? By the way, you know, when you go home today, you might end up writing up your family history, and at the end of this, I'll make some suggestions as to what to do and what would be next steps. So don't worry, we won't leave you hanging with some thought and not know what to do with it. So this time I can't see what the poll results are, but in this situation, this is a sparse family tree. It hasn't been transmitted to from one generation to the other, so it's more likely to be genetically complex.
And Clement, a lot of the families and participants have replied that it was complex, so they've understood in the questions.
Oh, fantastic. Okay, last one. I'll give you a clue. This is a trick question. So does this look like a single gene family or a complex one? Just look through it carefully. What did people write, Wendy?
It looks like it's a mix, Clement.
Yep.
Some people are not totally sure. Some people think it's complex. Some people think it's single, but they really love your advice.
So I think not being sure is a good answer. When you look at this second person that's affected with FTD, actually that person's married into the family and doesn't actually share any genetics at any point. So I would say this is a singleton or actually non-familial FTD type family history. So that's just something to look out for. You know, by chance alone, it may be someone marrying into the family with FTD, but might not be part of the illness. Okay, well done, everyone. So we're ready to talk about FTD now. We've done the background. I've summarized some of the thoughts about FTD and family history in the following slides. Okay, so family history of dementia and other disorders are common amongst families with FTD. However, only 10% of families have that strong single gene family history. When you build your family tree, it's important to remember that some of these single gene causes for FTD can also lead to other illnesses, such as motor neuron disease, and you've got to include that as affected in your family tree. And there are indeed other neurological problems that could be associated. So if you were building your family, it's best to discuss with your neurologist. Understand that there are some professional carers amongst us today too. We had a review in the Lancet a few years ago, and thankfully it's still up to date. And that describes much of the evidence behind the approach that we've talked about today, as well as further details about genetics for FTD. If a family does have the single gene form of familial FTD, then there are actually multiple genes that could be responsible for that. The three most common ones are the C9 open frame 72, C9ORF 72 gene, as well as open reading frame 72, as well as the tau and progranulin genes. These three probably represent 80% of families with a strong family history. There are a number of other genes that might be responsible. So the testing process is not very straightforward. However, the technology now has improved so that it could easily be done, that you could test for multiple genes simultaneously. So what does it mean for families and people with FTD? First, if there's a strong family history in your family, it'd be worthwhile consulting a neurologist or geneticist and consider genetic testing for a single gene disorder. The best approach actually is to start with someone in the family who actually does have FTD. Often we receive requests and questions from unaffected family members, but to identify which single gene is in the family, the best way is to start with an affected family member. Second, if a single gene mistake or mutation is found in your family, then it does have implication for each sibling and offspring of someone with FTD with a 50% or 1 in 2 chance of developing FTD. For most family where there isn't a strong family history, the good news is that generally speaking, the chance of a relative developing any type of dementia is only slightly higher than the general population, about 1.8 times. So that's good news. Okay, so I hope that's been interesting and of use to you. Let me summarize some of the things we've talked about today. So first, the family history of dementia and associated disorders is actually common in families with FTD, but for most family, it just means a slight increase, 1.8 times the chance of having dementia for other family members. However, for a small number of families, there might be a strong family history, and it might be worth considering having genetic testing. There's currently no cure for FTD or for genetic forms of FTD. However, genetic testing may allow a family to stop the genetic change from being passed to the next generation through IVF or pre-implantation genetic diagnosis. More excitingly, there are also gene-specific clinical trials running at the moment, either through specific gene mechanisms or gene therapy. When I was working more in the molecular lab back in the early 2000s, I would never have thought that, agents that we use on cell culture that work really well would one day become a therapeutic agent being trialed in humans. And that's what is exactly happening exactly now. So if you're concerned about your family history, or you think that you've got a strong family history, do chat with your neurologist or local genetic counselor or geneticist. And if you're in Sydney, or you pass by Sydney, you're most welcome to say hello, and I'd love to chat too. Okay, that's everything I have, and I'd love to hear from you and take some questions. Thank you.
Thanks, Clement. That was an excellent talk. So we have one question, which is there any genetic association between FTD and autism?
Wow, that's a great question. And Olivier probably, he's running a project on that, and he would have a better answer. But yes, I mean, over the past decades, we have observed situations where when we look at the family tree, then with people with dementia, actually not just FTD, in other types of dementia, familial dementia too, and then we notice there's someone in the family with autism. I don't think that's entirely well sorted out yet. Some of the current thinkings are maybe it is genetically complex, so there are multiple sort of genetic influential risk factors that added together that might point you one way or another. The single gene forms, we are less clear about autism and the association with that. So the answer is it is a bit complicated. It's still being worked through. And actually, if you're in Sydney, should they contact you, Olivier? Yeah. Olivier would love to be contacted. Any other questions?
Thanks, Clement. We do have another question. What's some general advice that you would give to family members who are seeking genetic counselling?
So that's a good question. So if there's a family member that's seeking genetic counselling, I think the first thing, there are two sort of situations. One is if you know that there's a single gene disease in your family. One is when you don't know. We'll start with the situation where you do know. So when you do know that there's a single gene change in your family, and you're interested to see your own status, that's called pre-symptomatic genetic testing. Usually when I see people in that situation, they might be worried about a certain symptom, or they might be planning to start a family, or their children might be planning to start a family. So if you're worried about certain symptoms, it's good to start with a cognitive neurologist, and they might be able to say, look, that symptom doesn't fit with this single gene illness, and that might reassure you. If it is about starting a family, and in fact in Australia, everyone having pre-symptomatic testing should see a clinical geneticist, genetic counselling, and that will be the first step. See your GP, and then they will refer you to the genetic counselling services in your local area. When you see them, they will often ask for the copy of genetic testing for your affected family members. So it's good to have that ready and have your family tree done. Okay, so that's the third situation when you know that there's a genetic change in your family or a single gene disease in your family. In the other situation where you don't know that, that's more complex, and often a lot of genetic services would say, look, you know, we can't really work this through because we don't know what single gene is in your family, and we can't even get started. And that's often when the research groups come into play, and we certainly would be most happy to see families in that situation in order to work out which of the single gene might be relevant. The key is actually to see someone affected in the family. I mean, some families might say, look, you know, my grandfather had this, we only knew what happened, but he's passed away since then. In that situation, you know, if they've had some sort of brain pathology, that would help a lot. But the starting point would be with someone who's affected. And we often go to, you know, see people in nursing home, etc., to work out what the relevant gene is in the affected person first, before then we can take it back to the unaffected family member. I hope that helps.
Thanks, Clement. And following on from that question,
Yeah.
How do people find someone to do genetic testing, or how do they contact a genetic counsellor?
Yeah, so in Australia, we're very lucky that there is well, in New South Wales in particular, there is a publicly funded service for pre-symptomatic genetic testing. All your general practitioner needs to do is look up in your local health area who runs the clinical genetics service, which is usually anchored in the main hospital, and send a referral, and then the clinical genetics service would contact you. I mean, if you're in a situation where genetic counselling is not that clear, either there's no diagnosed person in your family with a single gene disease, or you know, there's not good access, us at Sydney Uni and other groups would also be able to help.
Okay, Clement, and another question. Does a particular single gene mutation always cause the same variant of FTD?
So that's a really good question. So there are clear variability even within the same single gene disease. I mean, the classic example would be the C9orf72 single gene disease that some people in that family might just have motor neuron disease, some might just have FTD, some might have a combination. So within a particular spectrum, there is often variation. So I hope that helps it. So when you build your family history, it's good to be inclusive of everything. So hope that helps.
Thanks, Clement. That's all the questions that we have today. I think we might take a little bit of a break for people to use the bathroom or grab a cup of tea for the next series of talks. But please do continue putting your questions in the question box. We notice sometimes people are pressing the button to raise their hands. Unfortunately, we can't answer questions from that raised hand function. So please try and post as many of your questions in the question box as much as possible. And we'll begin the talks again in 5 minutes at 11 a.m.
Thanks for listening, and enjoy the rest of the day. Bye.
Hi everyone, can I just check that my microphone's working, please? It's Dharma here.
Hi, Dharma. I can hear you. It's Rebecca.
Wonderful, thanks, Rebecca.
Oh, okay.
Just a reminder to the audience, we're currently on a break and we'll be back on schedule and begin at 11 a.m.
All right, welcome back. And thank you again to Clement for a very interesting talk on genetics of frontotemporal dementia. Again, if you have questions, don't forget you can type up your questions in the question box. And also, if you're experiencing technical difficulties, you can, and you drop out of the session, please use the same link to log back in, and hopefully that will work for you. We are recording this session, so this session or part of the sessions will be made available at some point in the future on the FTD, World FTD United website, and also on the separate websites in Melbourne and Sydney. All right, so our next speakers are Professor Denis Velakoulis and Dr. Dharma Eratne, and in Melbourne. So Denis and Dharma are neuropsychiatrists based at the Neuropsychiatry Institute Royal Melbourne Hospital. And they both have clinical and research hats within neuropsychiatry. Neuropsychiatry is the bridge between neurology and psychiatry, and it's to provide a multidisciplinary approach to the diagnosis, assessment, and treatment of patients with complex neuropsychiatric conditions. And approximately 40% of referrals to neuropsychiatric patients will be diagnosed with a younger onset dementia, including frontotemporal dementia. So Dennis and Dharma, the floor is yours. Thank you very much.
Thanks, Olivier. Thanks to both you and Clement for starting today off so well. I've realised that listening to both of you that it's very well coordinated with our talk. Before Dharma and I begin, I'd like to acknowledge the traditional owners of the land on which the Royal Melbourne Hospital is located, the Wurundjeri people of the Kulin Nation. I'm going to talk for the first 10 minutes or so, and then Dharma will talk. Dharma has control of the slides, so I will be asking him to move them along as we speak. A brief outline for the talk. We're going to talk a bit about the symptoms which lead to a diagnosis of frontotemporal dementia and why those symptoms don't necessarily always lead directly to a diagnosis. We know that the diagnosis of frontotemporal dementia can be delayed, and that's because the symptoms are not always specifically, though, point to a diagnosis of FTD. Along the way, we'll talk about the reasons it takes so long to make the diagnosis, and also touch on some of the overlap with psychiatric symptoms and mental health issues. Dharma will then talk about some of the steps to diagnosis and what investigations and tests are required. Thanks, Dharma. Often it's not unusual to hear in retrospect, once we've seen patients and their families, to hear that early on in the piece they were told they're too young to have dementia, you're not forgetful, it's stress, are you sure, it could be something else. It's very common that we hear this story having seen people and made the diagnosis. On the other hand, there are explanations for this, and I'll try and touch on those as we go through. So the early symptoms, as Olivier has also flagged with us, involve behaviour, personality, emotions, and judgment. What I'll do is walk through the criteria for frontotemporal dementia and discuss each of the criteria or the main symptoms, and then try and help people understand how they overlap with other problems or mental health issues that people may have, which makes the diagnosis more difficult. Thanks, Dharma. There are many causes for changes in behaviour, personality, emotions and judgment, not just FTD, and they could be psychiatric or they could be neurological. Thanks, Dharma. I think it's fair to say that the commonest causes of changes in adults who first go to a GP with some of these symptoms are not frontotemporal dementia. The commonest causes are often mental health issues or other psychiatric issues, or maybe even medical or neurological conditions. So FTD is not necessarily the first thing that a general practitioner, for example, will think of if someone who's in their 40s or 50s comes along with problems with personality change or behaviour change. Thanks, Dharma. The diagnostic criteria for frontotemporal dementia include the symptoms, cognitive testing, and then investigations. There are three categories. Thanks, Dharma. Sorry. There are three categories of diagnosis, and this can sometimes be quite confusing for people who are not familiar with the criteria, because we use terms like possible, probable, and definite. And I know my team's certainly gotten into difficulties when we write NDIS applications, for example, and say there's a possible diagnosis of FTD, and people at the other end often think, well, it's not definite, so you don't have FTD. But there are formal criteria, and the possible diagnosis comes when the symptoms and the cognitive testing point to FTD. Probable includes brain scans, and then definite includes whether there's a mutation or pathology. Thanks, Dharma. So to some of the symptoms, there are the behavioural symptoms, so people acting inappropriately socially, or becoming a bit more coarse or rude or impulsive or careless. There are explanations for this that are not related to frontotemporal dementia. So these symptoms could be associated with alcohol or drugs, psychiatric illnesses, relationship, or midlife crisis, to coin a sort of a popular term. Thanks, Dharma. Apathy or inertia, we know, is one of the more difficult aspects of frontotemporal dementia. Lack of drive and lack of interest in things. Now, again, depression can often lead to apathy or inertia, and it's not uncommon that people who end up with a diagnosis of frontotemporal dementia will have been diagnosed with depression on the basis of lack of drive and lack of interest. Thanks, Dharma. Loss of sympathy or empathy, the ability to put yourself in other people's shoes, is a common symptom of frontotemporal dementia and one of the criteria symptom. But again, it can be seen in people who've been using a lot of alcohol or other substances. It can be seen when people are having relationship and other issues, and people will in relation who are having marital or relationship problems can interpret their partner's lack of interest or sympathy, etc., and describe a lack of empathy on their partner's part. So it's not just a symptom of frontotemporal dementia. Okay, next. Perseverative or repetitive behaviours. Now, some of them can obviously be quite abnormal and not within the normal spectrum of what we're used to, but there are a number of repetitive behaviours that people may well just describe to habits. Oh yeah, we heard Dad saying the same, using the same couple of words all the time, but we thought it was just a habit he picked up. Or it could be diagnosed as obsessive compulsive disorder, where people do have repetitive and compulsive behaviours. Thanks, Dharma. Hyperorality and dietary changes, we know, is often a telltale symptom of frontotemporal dementia, but eating more, using more alcohol, or smoking more cigarettes is not necessarily just a symptom of frontotemporal dementia. Binge eating on sweets or Coca-Cola, etc., may not necessarily just be a symptom of frontotemporal dementia. Putting things that are inedible into your mouth, that's probably a more telltale sign, though. Thanks, Dharma. When we come to the neuropsychology and brain imaging, even though neuropsychology and imaging can be very sensitive tests, we still come up with abnormalities in other conditions like depression or schizophrenia. So we can see brain changes in people with schizophrenia and bipolar disorder, and particularly involving frontal and temporal lobes. So having those changes on a scan does not necessarily mean that you have FTD, particularly if there are symptoms of schizophrenia or bipolar disorder in the present as well. Thanks, Dharma. We know that there can be a very long diagnostic delay, up to 3.5 years, because people, the symptoms of FTD are diagnosed as something else. We know that a previous psychiatric diagnosis is very common, and that the younger the onset, the longer the delay. Thanks, Dharma. 3.5 years is clearly a long time for things to happen: relationship, family issues, employment, financial decisions. A lot of things can happen in 3.5 years, which is why it's so important to reduce that delay. Thanks, Dharma. Very briefly, psychotic symptoms or symptoms that look like a schizophrenia can be seen in the lead up to some types of frontotemporal dementia. In 40% of patients who have the type of frontotemporal dementia caused by a mutation in the C9orf gene. Thanks, Dharma. I'm now handing on to Dharma, who's going to do the second half, which will focus on some of the investigations and the way we think about diagnosis. Thanks, Dharma.
To the cardinal sin of not unmuting. Thank you, Dennis, and thank you to the organisers and everyone for the fantastic talks this morning from Sydney, and Wendy and everyone for organising. So now I'd like to give you a bit of a flavour of some of the people that we see, and I'm sure this story that you'll hear is familiar to many of you in terms of your loved ones or personal, or people that you see in your clinical practice as well. just to highlight some of the challenges and why we've still got a long way to go to improve our early and timely and accurate diagnosis. So Kate was a 45-year-old woman who was referred to our service. She had a history. She's a high functioning, working in the finance industry, mother of 2 young children. And her story started really initially with stress at work and just not being able to manage the deadlines and pressures of work that probably had gone up a little bit, but not as much. And certainly she found that these are things that 5 or 10 years previous to this, she would have coped pretty well with. In the context of this stress, she had some trouble with her mood, some low mood and insomnia and trouble falling asleep. And she was initially diagnosed and treated for depression in the context of this work stress. Then she started to develop some other symptoms. She became very fixated and was called an obsession with a Hollywood actor, and to the point of writing repeatedly to him and emailing him and things like that, and started to bring up other questions of what was going on for her. Was this depression? Was this something else? And she saw initially in general practice and then a multitude of specialists, including psychiatry and neurology. And while this continued, it had significant implications for her and her family. That really caused a great deal of stress for the family. The husband and other family members became estranged, and certainly the marriage broke up in the context of really her symptoms getting worse and really struggling to understand what it was all about. And certainly for young children at school, it raised all kinds of questions and difficulties and stress for them as well. And then over the next 3 years prior to seeing us, despite multiple treatments for depression and her other kinds of symptoms, she continued to get worse, and she was referred to us. And I'll come back to her case once I talk a little bit about sort of the journey that people can go through. So as you've heard from Dennis and others, that the symptoms that Kate had and the symptoms that many people, particularly with the behavioral variant of frontotemporal dementia, have a long list of possible causes. And frontotemporal dementia certainly is one of them, and certainly psychiatric disorders, and probably of many of the dementias, by the very nature of the symptoms involved in behavioral variant frontotemporal dementia, as Dennis has talked about, really overlap from a clinical and symptoms point of view, but also from brain structures and networks with many psychiatric disorders. But there's a long list of other general medical or neurological conditions, many which are treatable and reversible, that need to be thought about and can present with symptoms and changes in behavior and personality and cognition, memory, language, and so on. And this is the process of going through the diagnosis, is going through a multitude of different ways of looking at the clinical presentation and brain functioning to make this diagnosis. And it certainly is a process. None of these, the conditions that have just a single blood test, unfortunately, that can just quickly tell you exactly what's going on. And so this is the importance then of the history, the clinical and physical and neurological examination, the utility of a multidisciplinary team. We've heard a little bit about the complementary roles of neurology, cognitive neurology, psychiatry and neuropsychiatry, neuropsychology, allied health, occupational therapy, speech pathology, as we'll hear a bit more, to try and sift through the complexity of each individual person and family's history and situation. And then there are the additional blood tests and other tests, including brain scans, genetic tests. And certainly, as you're getting a sense of, it's a process and it takes time, and there's lots of ups and downs, can be lots of ups and downs along the way. So the current state of affairs is that the history is still incredibly important. And a lot of what we're going through in the history in our clinic is trying to understand and trying to pick out, are there any red flags that would point us towards what, in a general practice setting, is still a rare disorder compared to the much more common depression, for example, or even bipolar disorder. And what are some of the red flags? The age at onset of the symptoms, particularly if it's an unusual or a later onset over the age of 40, for example. If it's a really rapid progression, if people don't have they might have some of the symptoms, say, of depression, but not the full don't meet the diagnostic criteria for depression, things are progressing quite rapidly. The past history, does someone have, is this a long history of a primary psychiatric illness, or this is really a sudden change? Is someone who's never had a history, and this is a very new presentation later on in life? Is there family history of unusual or late onset psychiatric illness, or even suicide, or history of neurological or cognitive disorders like frontotemporal dementia or motor neuron disease? What are the other medical symptoms and medications and things like that? And are there any red flags on the physical and neurological examination that would point you away from the what you'd be expecting to see in depression or bipolar disorder? So are there Parkinson's-like symptoms, stiffness or tremors, abnormal movements, problems with eye movements, for example? So then moving on to the further tests to confirm the diagnosis, many of the blood tests are to not necessarily say this is frontotemporal dementia, but to rule out other kinds of other conditions that could be mimicking it, like thyroid dysfunction, just as one example. Cognitive and neuropsychological tests to have a more in-depth understanding of cognitive strengths and weaknesses, and to the profile, and to map that onto the profile you'd be expected to see in frontotemporal dementia or other disorders. Brain scans like MRI scans to look at the shape and size and structure of the brain, and if there's other pathology like strokes or tumors or masses that could mimic the presentation of frontotemporal dementia. And then functional imaging like SPECT and PET scans that look at the perfusion or metabolic activity of the brain to get you a sense of how the brain's working. Are there areas that are underactive? And then, as you've heard from Clem's excellent talk about genetic testing and the promises and the challenges with that, and in terms of access and funding and things like that as well. So coming back to Kate, as you remember, she had this history of just continuing to get worse despite multiple treatments for depression and other psychiatric symptoms. And the history really unfolded in that she developed worsening and new symptoms, becoming very much more impulsive, loss of empathy, and really completely unable to work. And she started off with a dramatic change in her food preferences, really preferring sweet foods, but then progressing to the point of putting inedible objects into her mouth. And what we initially thought of as sort of mannerisms and stress-related, just little sort of fidgetiness, became much more obviously stereotypies and repetitive abnormal movements. And certainly by this time, her cognitive profile on even just bedside cognitive testing demonstrated severe executive dysfunction and frontal and temporal atrophy or loss of volume and underactivity on MRI and SPECT imaging. So meeting the diagnostic criteria for probable BVFTD. So some of that, I was very mindful when you put your talk into, and you've got this list that it can look like, that the process follows in this nice linear timeline, and A plus B equals C, to this and this and this. And what we know is, and as Dennis alluded to, the diagnostic delay, and certainly what's used in the literature in genetics a lot, but highly relevant to disorders like frontotemporal dementia, is the diagnostic odyssey, where for many years, and this is a picture that is an example of someone we've seen in our clinic, and not uncommon, and I think would ring a bell with many of you in the audience and speakers in their clinical care and health professionals, of people going through multiple investigations, multiple specialists, often with misdiagnosis, with diagnostic uncertainty, great degree of healthcare costs as well, but most importantly, really negative outcomes for people with symptoms, their families, young children, and so forth. So we've got, despite great advances, we've still got a long way to go to really improve and reduce this diagnostic odyssey and improve outcomes for everyone. In the future, there's lots of promise. There's a significant, as we're seeing today, I think, and in this whole day, there are these excellent, incredible teams and multidisciplinary international collaborations that are working so hard on improving this from all different angles, from understanding the basic biology and the genetics to understanding how to help and improve symptoms and quality of life. And as we've heard from Clem, there have been significant advances. The C9 or F72 gene association in 2012, I think, is a significant advance, and it continues to advance rapidly. There are new technologies like types of scans looking at tau. There's a very recent development of a blood test that could promises great diagnostic potential for just being a blood test for Alzheimer's disease. And as I'm sure we'll hear more in Dr. Rebecca Ahmed's talk about research, and certainly our group and many others in the world are looking at biomarkers like neurofilament light that's showing a great promise as a blood test to help distinguish frontotemporal dementia from primary psychiatric illness, which is, as we've heard so far, is a very challenging and common clinical dilemma. So to conclude our talk, the symptoms of FTD, there's a great degree of overlap with many other disorders, including primary psychiatric disorders. Making the diagnosis, therefore, can be tricky and can be associated with a complex and difficult and traumatic diagnostic odyssey. The history, the clinical examination, and multiple tests are required to rule in and rule out differential diagnosis and reach the diagnosis of frontotemporal dementia. And the utility of a multidisciplinary input, particularly for complex presentations where the expertise of neuropsychiatry, for example, and neurology can come together to help with these challenging situations. And it's a rapidly developing field, and there are many promises for the future. Thank you very much. That's the end of my bit, and I'll hand over back to Dennis. Thank you.
Thanks. Thank you, Dharma. And also thank you to our large and wonderful team, particularly Wendy, who's done so much work to help set up today. I think it might be time for questions. Thanks, Meryl.
Thanks, Dennis and Dharma. That was an excellent talk. So we have a question here. Is diabetes a risk factor for FTD?
Not that I'm aware of, Meryl. It can certainly work the other way, that people with FTD, particularly if people are eating lots of sweets, overweight, etc., may develop diabetes, but I'm not aware of any link the other way.
Thanks, Dennis. And would you both mind explaining what are some of the psychiatric symptoms that occur in semantic dementia versus PNFA, progressive nuclear palsy?
Thanks, Meryl. I did see that question. I've had a chat with Wendy. That'll be covered in Wendy's talk, which is coming up next. So stay tuned.
Thanks, Dennis. And do you think there's any link between the long-term use of antidepressants and frontotemporal dementia?
Again, none that I'm aware of in terms of the antidepressant use causing dementia. I'm not aware of any evidence to that effect.
Okay, and we have another question from the audience. How do I cope with my friends and family not accepting the diagnosis of FTD? They, along with my husband, who has FTD, thinks it's fine as he appears very normal at times.
Yes. Dharma, do you want to?
Yes, thank you. That's an excellent question, and it's something we see a lot in our clinic, and can be really challenging. And certainly in my genetics work as well, this applies to people sort of understanding and willingness to look at sort of genetic causes as well. So it can be really quite a complicated issue. I think one of the things we often talk about in the clinic is just everyone. It's sort of like with coming to terms and coming to a sense of adjustment to anything, and the principles of stages of grief and things like that can apply, and everyone can go through different stages and different times. And there's so many variables that come into it. And particularly, with, it's one of those things, if you could say, right, this is the blood test that says that your sugars are elevated, you've got diabetes and things like that. But it applies even to illnesses like Alzheimer's disease, but for frontotemporal dementia, where there can be this overlap with symptoms of depression and other disorders, and they may have been given diagnoses, there can be variability of fluctuations as well. And people, their symptoms are modulated by their environment. So we often see that in some families where they say, oh, when so-and-so is staying with me, I don't see any of these problems. And it can be really, really quite difficult. And one of the things that can be helpful is, the utility of the neutral service, where one of the things we're commonly doing is having family meetings where we try to get everyone into the same room. And often that can be really quite tricky and can get really heated, but to disseminate and share information, and often coming from from us. And I'm not saying it just happens. It's not like you have this one meeting, but over time, and part of ongoing services that provide ongoing care is a big part of what we do, is this journey along with families. So it certainly can be very difficult. I think we'll hear a little bit about some from Wendy and Dana and others about some of the more specific strategies, but certainly something that we grapple with very frequently and happens to a lot of families.
Yeah, I was just checking that some of these very questions are covered later on in the sessions related to carers and behaviours.
Thanks, Dennis and Dharma. So that's it for the questions. We'll move on to the next speaker now, Wendy. But all the questions are great, and please do continue posting them in the question box, and we'll try and answer as much as possible. Thank you.
All right, I might jump in quickly. There was a question about the diagnostic delay of 3.4 years. That's based on the medical literature, and it's obviously an average, meaning that some people may be diagnosed at 1 year, others at 5, but the average is 3.4. Now, it's my pleasure to introduce Dr. Wendy Kelso. Wendy's been instrumental in organising today. Wendy's the Senior Clinical Neuropsychologist at Neuropsychiatry here at the Royal Melbourne, and was a clinical lead on our Better Care Victoria Neuropsychology Telehealth project called Bright Yod. She was instrumental in establishing our Melbourne Young Onset Dementia Service, which is a clinic specifically designed to assist patients and families with young onset dementia. She's also a frontotemporal dementia support group facilitator with Dementia Australia, and has worked with people with FTD for over 15 years. Thank you, Wendy. Just swap seats.
Thanks, everyone. So what we're going to do now is I'm going to play a video, and this video is Billy, and Billy's 29 years old and the primary carer for his father, who was diagnosed with behavioural variant FTD in 2018. So Billy's father deteriorated quite rapidly and is now in permanent care. And in his video, Billy reflects on the road to diagnosis and what the experience was like for the child of a parent with FTD. So just give me 1 second.
Hi, my name's Billy. I'm from Sydney, Australia. My father got diagnosed with FTD, behavioural variant, in the beginning of 2017. I was 26 at the time. I was living in Melbourne and I got a phone call from his GP saying that my dad has some mental health issues. And through an MRI, it showed that he had some changes in his brain, and we quickly found out that he had FTD. as a 26-year-old, I then realised that my dad probably hadn't been functioning well for quite a while, and it didn't occur to me what the problem was. I just thought my dad's getting a bit older and a bit more senile. The first sort of symptoms that I realised was that my dad became more introverted and excluded himself from social activities. Although my dad was presented very well, he was very healthy, and I started going to social things without him as a 16-year-old, 17, and it got to the point where my dad didn't really know what I was doing at school, and I finished school and he didn't come to my graduation. And it wasn't like he didn't care, he just seemed a bit sort of senile and couldn't really think or organise beyond his own little life. So fast forwarding from that, he ended up engaging in another relationship which didn't work out too well, and as time went on, my dad started hoarding things, collecting things without any explanation. He couldn't explain why he was collecting things, and he was very strong with routine, and he did the same things every day, the same walks, the same places, and he kept up. As his FTD became worse, he actually became more active and went for really long walks, to the point where he would walk all day and come back and forget where he'd been, and that's where I decided that it was probably time to basically institutionalize him, because he wasn't safe on the roads. He was running across streets and not paying attention to the traffic and things like that. Yeah, it's been a fairly difficult journey, particularly with my dad. With dementia being loss of personality, a personality disruption in his personality. I mean, that's very difficult to deal with, particularly when it's happening over time and gradually getting worse. So for a young person like myself, trying to find my own identity, having a single parent who is also gradually who's actually getting worse, and they don't even know who they are as a person. It's difficult to get your head around. I was in a dark spot for the last 3 years, trying to figure out how to deal with my dad and all the social issues that he got himself into, particularly with his with another relationship, and me being the sole carer with no family support. Yes, it was really difficult. I eventually put my dad into a nursing home, and probably the worst experience that I've ever had in my life so far. And I eventually just had to accept that's what it is, and I did the best thing that anyone could have done. And I did have to realise that I had to look after myself. That's extremely important. And I found some people that gave me some good advice, that I had to look after myself, and my dad wouldn't have wanted me to suffer trying to look after him for the next however many years he lives. Work wasn't easy to do, particularly when I wasn't in a good headspace, and I was fluffing around for about a year, and I just had to get things together. I managed to find some things I was passionate about, and I committed to that, kept myself healthy, and now I've got a fairly promising trajectory, and I'm pretty happy with where I am and where I'm going. So I think it's important to not get too involved with your emotions, particularly when you can't do anything about the situation. And I think it's extremely important to look at your own future as a carer and, you know, realize that you have far more potential than the person you're caring for, and that person you're caring for wants you to succeed in life. So I guess that's probably my last bit of advice, is to do as much as you can for the person you're caring for, but also that can't limit you as a person and your relationship with other people, your friends, and your wider community.
Okay, thanks everyone. So I'm going to talk about managing behaviours in frontotemporal dementia, and I'll just get up my slides now. Okay, great. Before I start, I just want to thank a couple of people. Tracy Wardle has been instrumental in organising World FTD United, and Margie Beasley, and I want to thank them so much for their fantastic support and tireless dedication to making this day happen for Australian audiences. I'd also like to thank Colin McKinnon, who's a clinical nurse specialist and dementia specialist who I worked with in Sydney, who's also been instrumental in helping me understand about behaviour, and all the families and people living with FTD that have taught me everything that I know today. So I'm going to talk about managing behavioural changes in FTD. And Sarah Farrand, who's one of the psychiatrists, unfortunately is unwell today, so I'll just be talking by myself. Okay. The first thing that I just want to quickly talk about is Olivier has mentioned already the changes in the brain that occur in behavioural variant FTD, but I just want to talk about, you can see here the frontal lobes. So they're the main areas where there's, so responsible for controlling personality and behaviour, and particularly things like planning, problem solving and decision making. And also the temporal lobe down here, where is affected in semantic dementia, where people have difficulties understanding the meaning of the word, understanding language, but it also controls your emotional systems. Just going to briefly talk about this picture here. So this is looking at the spectrum of frontotemporal dementia. And I know on the chat there's been a couple of questions about PSP, so progressive supranuclear palsy and corticobasal degeneration. Now they're considered forms of frontotemporal dementia, just like semantic dementia and progressive non-fluent aphasia are. And even some variants of motor neuron disease can have frontotemporal dementia that coexist with them. So you can see here on this little continuum tree that depending on what type of frontotemporal dementia you have, you may have different cognitive symptoms, different behavioural symptoms, different psychiatric symptoms, and different language symptoms. And I'm going to go through some of that today. Probably the most important thing to realise is that the behavioural changes that occur in frontotemporal dementia are due to brain changes. And many people find that they may have a tendency to blame the person with dementia, and really it's the disease that's causing all the symptoms. And that can be incredibly difficult if you're caring for someone with FTD, not to blame the person when it's extremely stressful or there's heated arguments, but it's always good if you can try in moments of calm to try and remember that it's actually the disease that's causing these changes. So as I was talking about before, it's a little bit like just having a broken leg, but the person's brain is broken. It's not working the same. And because of the loss of brain cells that occur, particularly in the frontal and temporal lobes, they cause the symptoms of FTD. There's ways of managing the behaviours, and we've often found as well that carers sometimes find that they're also blamed for the person with FTD symptoms because they can't actually manage some of the behaviour out in the community. So it goes both ways. The person with FTD often gets blamed for the behavioural symptoms, but sometimes family members can also get blamed if they start behaving in an inappropriate or antisocial way in the community, and many family members don't know how to basically fix it so they can go out on social outings. Okay. I'm going to talk a little bit about caring and personality types in FTD now. So some people are born carers, and Dana's going to cover this a little bit more in her talk with Sam this afternoon. And some others are not suited to the caring role. So you need to think carefully and honestly about yourself and about your own strengths and limitations. So why are you the carer? So are you the carer because of love, duty, obligation, is it guilt, expectation, financial, or there's no one else available? What contributes to behaviour? So relationship with a person prior to the illness is one of the main things. Belief systems and values. So some people, for example, maybe from a religious background, or they have a cultural way where they think people should behave in a certain way. And if the person with FTD breaks those rules, it can be harder to manage. Also things such as physical and emotional burnout can affect behaviour. And sometimes if the carer is finding that they're extremely stressed or extremely tired, that they therefore can't manage their behaviour as well and their interactions with the person with FTD. Expectations, levels of stress, worry, burnout, and the amount of support the person has to look after the person with FTD. Another thing is education. So if you understand why the person is having the behavioural changes, it can assist then in trying to manage some of those behaviours.
Just your screen sharing. Sharing full screen.
Sorry, Dharma's just going to check a technical issue. Great, thanks, Dharma. So apparently I've been sharing too many slides, I think, but I think Dharma luckily has come to the party and fixed it. Is that right, Dharma? Yeah, fantastic. Yeah. Great, okay. So in terms of general principles, the most important thing is to remember the person. Yeah. So remember what they were like before they started to develop the illness. And I think that can be extremely easy to forget when there's lots and lots of difficult behaviour changes, and the person with FTD may not represent who you married or who you were looking after before, and that can be really, really difficult. Try not to take the behaviour personally, and if you can, use humour. And I know that that can be really difficult, but sometimes it is so difficult that if you didn't laugh, you'd cry. Remain as calm as you can, and we often find that if someone's in a predictable routine that they can cope much better, because it takes the demands off their brain, so they don't have to, the cognitive load is reduced. So for example, if someone has frontotemporal dementia, it means that because of the loss of brain cells, they find a lot of tasks more difficult than they did before. So if you try and keep things predictable and stable every day, then it takes off that cognitive load so they can actually act and act at a higher level and be a bit more effective in accomplishing some of the tasks that they'd like to do. You essentially need to act as their frontal lobes, because their frontal lobes isn't working as well as it did before. And if possible, keep them involved in activities and hobbies that they've really enjoyed in the past, and maintain connections with family and friends. Okay. Now, this is a little bit of a behaviour chart. So what do you do when the behaviours are difficult? So if the behaviour is not harmful, is it possible that you can accept the behaviour as part of the illness? It may not be desirable, but if it's not harmful, is it possible that you can change your expectations and be a tiny bit more tolerant and accept the behaviour as part of the illness? Sometimes that's possible and sometimes it's not. So if it is possible, you can focus on the remaining abilities. But if it's not possible, can you alter your response, possibly increase your tolerance, reduce your expectations, or modify your own behaviour? And can you develop a list of strategies and make a plan, or modify your environment to try and stop the behaviour from occurring? And we often find distracting and reassuring the person and changing the routine can be very useful. So what is cognition? So when Olivier was talking before, he was going through all the different areas of the brain that are affected in FTD, and many different cognitive skills are affected. Sometimes though, in the early stages of FTD, the person isn't diagnosed, particularly the behaviour variant, for quite later on in the journey, because the behaviour changes are very prominent, but they actually do quite well on cognitive testing. And we often talk about a white coat syndrome, where they may go to the doctor, for example, and they can actually behave quite well for that half-an-hour appointment, but then when they leave the room, then some of the behaviours come out as well. And some neuropsychological tests aren't very sensitive at picking up behavioural and changes in what we call social cognition, and they're more useful at picking up things such as memory difficulties or planning and problem-solving difficulties. So what are some of the changes that happen in BVFTD? So Olivier and Dennis and Dharma and Clement have touched on this a little bit before. The biggest, particularly for behaviour variant FTD, is personality change. So the person isn't able to demonstrate as much emotion as they did in the past, and their ability to empathise with the person that they're living with, or with their children, or with their parents and friends, is reduced. The warmth and understanding and ability to put themselves in the other person's shoes is really limited. And there may also be a change in loss of intimate relations, so in sexual relations, for example, but even in physical touch. And a lot of people with FTD, while we hear often about people being very disinhibited, often they're also apathetic, and the most common sexual changes are actually no interest in sex, no interest in tenderness or physical affection, rather than too much interest. Often they become quite self-centered and inflexible, and it may mean that they get stuck on a certain train of thought, and a little bit like they're on one set of train tracks and they cannot divert their thinking to go on a different train track to get to a different line of thought or a different problem or a goal, for example. And people with BVFTD, usually one of the first symptoms is a lack of insight, that they're not aware that they've got these changes, but everyone around them is. Now that's a little bit different for the language variants, and I'll come and talk about that in a sec. Some of the other behaviours are social avoidance, so not wanting to go out and be in social situations anymore, or if they are in social situations, not being able to behave the same way that they did in the past. What we call perseveration, which means doing the same thing over and over again. For example, they may be wanting to listen to the same music over and over again, or eat the same food, or say the same couple of phrases under their under their tongue, for example, over and over. So things that they do very regularly in a very fixed and repetitive type of way. Gluttony is often a feature as well, where people overeat, particularly sweet food, but it can also be salty food, and even non-food items such as soap, for example, where people just stuff food in their mouth, often swallow before they've actually chewed it particularly well, and this can be a real difficulty for families. And it may be that you go out socially with someone and the person with BVFTD may steal food from another person's plate, and that can be really hard for families to manage. Apathy is an extremely common symptom in BVFTD, and I'll talk about that a little bit later. And this can all lead to relationship stress. Some of the less well-known features of frontotemporal dementia are changes in temperature and sensation, and some of the Frontier group and people across the world have been looking at particularly eating behaviours, but also ability to feel pain and regulate pain, feel if it's hot or cold, for example, and also understand their bodily sensations. So you may find that some people with BVFTD, for example, find that it's extremely cold outside. They feel that it's cold outside, even though it might be a 35-degree day, and they might put on 20 jumpers and a coat on top, and the family are thinking, oh my goodness, what's going on? But they're so inflexible that they refuse to actually take the jumpers off. So they aren't able to regulate their temperature the same way or feel and experience temperature the way that people that don't have FTD do. People with BVFTD and also semantic dementia can find it difficult to read emotions, and this also occurs in progressive non-fluent aphasia and in PSP and corticobasal and some of the other behavioural variants that we mentioned before. So it means that they don't have the same ability to recognise particularly negative emotions as other people do, and I'll come to a slide on that in a second. They're also unable to recognise the signals to stop a behaviour. So, for example, they may hug a stranger, or they may go up to someone, for example, in their street, or ask their church minister about their sex life, you know, not knowing what's appropriate social behaviour in a certain setting and not knowing when to stop. So a lot of people with BVFTD can be very intrusive into personal space. They can be right next to you the whole time, not realising that you need a little bit of space, and families find that really hard. Sometimes they lose their moral code or judgment and make decisions that probably are not wise. So, for example, we've seen lots of people over the years that they may have a huge increase in spending. They may start buying a lot of alcohol. They may start having affairs with other people, which they would never have done in the past before the brain changes occurred. And ability to understand sarcasm is also reduced. So we find with people with BVFTD that you have to talk to them directly in clear language for them to be able to understand, because they don't pick up the subtleties of sarcasm. So this is a slide here looking at the ability to read emotions. So you can see here there's sadness, anger, happiness, disgust, surprise, and fear. And there's been some studies done, particularly in Sydney. Fiona Comfort's group has done a lot of work in social cognition, same with Olivier and John, just looking about which emotions can people with frontotemporal dementia pick up and which can't they. They're able to recognise happy emotions and positive emotions much more easily than negative emotions. So, for example, sadness, anger, disgust, and fear, they find much harder to read that facial expression. So if you're feeling sad yourself or you're feeling very angry, the person with BVFTD in the room with you may not recognise that facial emotion. So they may actually have to tell them in words or express in another way the way you're feeling so they understand. This is a study that Fiona Comfort did in 2011, just looking at recognition of emotion in FTD, and it looked at a variety of variants. So behaviour variants, semantic dementia, and progressive non-fluent aphasia. And this is anger, disgust, fear, sadness, surprise, and happiness down the bottom. Blue is the control, green is behaviour variant FTD, the yellow is semantic dementia, and the purple is progressive non-fluent aphasia. So you can see in terms of people's ability to be able to identify the facial emotions in both, you know, for example, in anger, virtually all three types of FTD, it's reduced. Disgust, particularly BVFTD and semantic dementia, and fear, you can see all of them have difficulty recognising fear. Sadness, surprise, but they can recognise happiness. So it's really the negative emotions they have more difficulty with. One of the questions before was about semantic dementia and what are the changes in behaviour, but also psychiatric changes that people notice. Traditionally, people did a lot of research in semantic dementia and progressive non-fluent aphasia and focused very much on the language features of the condition, but didn't focus as much on the behavioural changes or the psychiatric changes, emotional changes. But the more research that's been coming out now shows, particularly in semantic dementia, and as the disease progresses more into the frontal lobes as well, that they have quite similar level of behavioural change as behavioural variant FTD, but slightly different characteristics. So particularly in the right side, it's semantic dementia, people lose the ability to recognise faces. Often there's a preoccupation with jigsaws and puzzles and different picking up, for example, cutting up newspapers to pick out a certain thing each day, or unusual kind of repetitive interests. There's often a narrowing of interests, and it can be a little bit like in autism, where they get fixated on a certain thing, like picking up fluff off the ground or emptying rubbish bins or doing a range of different things. And that can be really difficult for families to manage. Clock watching happens a lot, so people find that they're extremely regimented with time, and they may have to have their meals exactly at 5 o'clock or exactly at 12 o'clock, or they have to leave exactly to get the 3:15 train, and they cannot be distracted by that. And there's lots of compulsions and rigidity in somatic dementia, particularly regarding food, particular types of food that they will and won't eat, and activity. And somatic dementia as well, because they lose the understanding of the meaning of language, it can be hard for them to express their feeling of body change. So some people also have somatic symptoms that they can't explain as well, such as headaches or changes in sensation in their body, which they find it much more difficult to explain. And with the food, in both somatic dementia and behavioural variant FTD, a lot of the, it's the quality of the food that they love, the intensity of the taste that goes to the reward system. So they tend to crave sweeter foods because it's much higher, more pleasurable in terms of rewards, and it gives you a bit of a hit, like a drug, I suppose, in your brain. And the same with really salty foods or something they need the actual flavour of the food to be stronger, but they also need it to be extremely pleasurable. So foods, for example, like cauliflower or turnip, which can have quite a bitter taste, they're very turned off by. With progressive non-fluent aphasia, that's where there's a decline in ability to be able to express their speech clearly, and often speech is quite difficult to listen to because it's so effortful and at times robotic, and the grammar's affected. And they've found that people with progressive non-fluent aphasia, their ability to recognise emotions has also declined. And as the illness progresses, that there is apathy or a lack of drive and motivation, and that they can become more inflexible and not have the same level of empathy. Generally, in the early stages to moderate stages of the illness, often it's just language changes and the behavioural changes come later, and they tend not to be as severe as in somatic dementia or behavioural variant FTD. And progressive non-fluent aphasia, some people can start having a language presentation of progressive non-fluent aphasia and then develop something like such as corticobasal along the track. So sometimes the lack of fluency in language can be the first symptom, and then the diagnosis can change slightly over time, or the symptoms can change. So what happens if people have difficulty paying attention? So what type of difficulties does that cause? So you can imagine if you're finding it difficult to pay attention, you can't follow through with a task, and you find it very difficult to multitask and sustain concentration for any length of time. And most people with BVFTD, their concentration span is reduced. So if you're expecting them to be able to pay attention to the same degrees they didn't before, it's going to be much more difficult. Executive functioning is moderated by the frontal lobes and the connections of frontal lobes to the other parts of the brain. And this is having difficulties with planning and organisation, being much more impulsive, disinhibited, having rigid thinking, and being unable to start or stop an activity. So the starter motor is broken and they can't work the brakes as well. We often say that the gates around the emotions are not working as well, so they can't filter what they say comes in or out as easily, and they can't check their own behaviour. So disinhibition occurs with some people with FTD, not all people, but certainly with a vast majority of behavioural variant have some level of disinhibited behaviour at some stage of the illness. And often it could be a lack of social tact, and they can act in a way that might be embarrassing for families. And we often talk about it with an inside thought versus an outside thought. So for someone that doesn't have FTD, they may have a thought that someone may be, for example, overweight, but they wouldn't say that. It's an inside thought. But for people with behavioural variant FTD particularly, those thoughts become outside thoughts. So they may talk about, make negative comments about people's physical appearance, about their race, about their sex life, about a whole range of things, or their religion or politics that they may not say in normal social situations. And they often find it really difficult to understand the other person's point of view, that the other person may not want to engage in sexual relations, or the other person may not want to go out with them, or may not want to have a conversation with them. They can't understand the body language and the changes that that causes, and they can't understand personal space. And they can't delay gratification for a long-term goal. Yeah, sure. So in terms of managing disinhibition, I think firm and consistent reminders that behaviour is not appropriate is often really useful. And we find distraction, redirection and humour is often really good. But it's important to think about some of the potential causes. So sometimes behaviour is an expression of an unmet need, not always in BVFTD, but occasionally. So you need to think of, for example, is the person lonely? Are they being stimulated enough? Have they got enough activity? Other things that may be causing the behaviour. And try and avoid triggers as much as possible and make sure the person's getting enough exercise and physical activity to manage things such as agitation. With aggression, so aggression can occur when there's a lack of impulse control, and also if someone's very frustrated or humiliated, for example, that they may be more likely to be aggressive. So if you're asking someone to do something that they can't do anymore because they don't have the cognitive ability to do it, often they can get more frustrated and it's more likely that they'll become aggressive. They can't meet their own needs anymore, and they may also get very anxious, but their way of expressing anxiety or worry about being in a certain situation is to be physically aggressive because they might feel unsafe. So how do you manage aggression? So don't argue or rationalise, that's the first thing. There's no point trying to rationalise with someone that has behaviour variant dementia because they don't have the capacity anymore to be able to think in a rational, logical way. Distract where possible and make sure that your body language reflects the state that you would like them to be in. So for example, if they're very heightened and they're quite feeling aggressive and out of control, you need to be as calm as you possibly can, lower your tone of voice, make sure your body language is not with your hands crossed, but for example, your hands by your side, open, maybe go to the side of them so you're not front on, not confronting them. And these things can often reduce the tension in the room. Don't crowd or touch the person if they're being aggressive, and try and empathise with them as much as you can. And again, avoid triggers. And if it's safe to leave the person, if they're very aggressive, then just simply leave the room, and then you can try and identify the triggers after. If it's extremely unsafe and you're worried about your own personal safety, then you need to leave the room immediately and try and call the police or call an ambulance or get other family members in to support you as much as you can until they've got a chance to calm down. In terms of managing finances, look, I won't spend too much on this, but many people with BVFTD and also other variants of FTD find managing finances very difficult, and they're much more likely to be exploited by other people in the community. So putting them on a do not call list and giving them only a certain amount of small money on a credit card, for example, so they can't lose too much money, is often useful because that still gives them some sense that they've got control of their money, but that they're not going to fritter away the family fortune. Shoplifting can be an issue, so we recommend people to shop local, be able to talk to the shopkeepers about the situation. Dementia Australia have companion cards where you can explain to the person that the person has dementia and that they may shoplift and then return the items afterwards. So what's apathy? So it's a lack of concern and motivation and a loss of interest and a loss of engagement. And it's probably one of the most common symptoms and the most debilitating symptoms in all forms of FTD. And it means if in the severe form that the person doesn't have the interest in doing their self-care anymore, that even things like showering and dressing, they are totally amotivated to get along and do that. So this is when motivation occurs in normal people. So you can see here in the frontal areas of the brain and the striatum and the connections. Yeah. And apathy is divided into a couple of different types. So there's affective symptoms of apathy, behavioural symptoms of apathy, and cognitive. So affective may be a blunting, a loss of empathy. Behavioural would be withdrawn or inability to start or initiate behaviour. And cognitive is a lack of interest in routine, for example, and difficulty planning to achieve a goal. So there's been quite a lot of work in positive behaviour support, and that's been run out of Sydney and also Flinders University. I'm just going to show you the positive behavioural support manual, which is fantastic if you want to download it. It's on the web. So really it's talking about what can you do to make the behaviour a more positive experience for the person and engage them in things that they've always loved to do and support them to be able to do the things that they once did. So rather than doing it for them, setting them up and mirroring so they can mirror your behaviour. So if you're starting to do, for example, cooking a meal, You start alongside them, you set it up, for example, so the carrots are out there, the knife's beside it, you start chopping carrots and show them what to do, and then get them to support you as you go along. And that's the Positive Behavioural Support Manual by Linka Fisher, Claire O'Connor and Olivier Piguet. Okay. In terms of insight and indecision, so that is very common that people don't have much insight anymore. And when you're asking them, for example, do they want to do activity, often they'll say no, and that's because it's an overlearnt response. It stems back right to childhood. Sometimes people with behavioural variant FTD and other forms can act more like a child in their behaviours. And so it's much more useful not to give them the option to say no, or if they do say no, don't assume that it actually means no, and minimise the number of choices that they've got. We often find that if you'd like someone to do a certain activity to increase motivation, offer them a reward, or for example, if you want them to go out on a social outing and you've been having trouble getting them to shower, link it. So for example, if they always get to go out to the cafe with a friend, make sure that they have to have a shower beforehand if it's a shower that you want them to have. So it's linked to a positive experience, more likely for the behaviour to occur again. In terms of circuit breakers, so sometimes things go wrong every day and it's just incredibly difficult to manage some of the behaviours. So we find that people can often use music or singing. Often people, even if they don't have much language left, are still able to sing if you play a favourite tune, or if you turn on some music that you both like or one of you likes. It can just lift the mood and just break the circuit if things are getting difficult. Laughing or crying or screaming in a cupboard or just making sure you've got some time out. And often things like aromatherapy and exercise and being in nature or going out for a walk, or either you or the person with FTD or both, can just break the circuit for that particular time. And make sure that you use, so if they've got particular types of behaviours or activities that they do repetitively, use them to your advantage. So if they like, for example, watching a certain show over and over again, use that if you need to have a break. So in summary, FTD is a brain disease and every individual with FTD is different. So all of the behaviour changes I've talked about today, not every person will have those changes. Some will have some will have others, and everyone's an individual, and who they were as a person before they developed FTD will impact how their behaviours are exhibited when they have FTD. It affects the whole family, and taking care of yourself is incredibly important. So thank you very much. I think now there's some questions. Hi, Claire.
Hi, Wendy. Thank you so much for your excellent talk. We don't have any time for questions before we move on to the next talk now, but we might have some time in a break later to come back to some questions for you, Wendy. So from the audience, if there was any, we've seen some great questions in the box, so we'll endeavour to get back to you, and we may have time for Wendy a little bit later. So Wendy, I'll hand back to you to introduce the next speaker.
Yeah, great. Thank you, Claire. So I'm going to introduce Camille. So Camille Paint has worked as a speech pathologist for almost 20 years in Melbourne and in London. And she primarily works with people who have neurological conditions such as stroke or progressive diseases. So in addition to her clinical work, she's studying for a PhD at the University of Melbourne, exploring decision-making capacity for people living with motor neuron disease and their carers. So I'm just going to get up Camille's talk now.
Great, thank you so much, Wendy, for that introduction and for a fabulous talk. So I'm very happy to be here today to talk about speech and language changes in FTD. go, sorry. So what I'd like to talk about today are common difficulties experienced by people with FTD. Sorry, change it, there we go. And the impact for carers, give you some education about swallowing, provide you with some general strategies that hopefully you'll find helpful. And I thought you might be interested in what we know about speech pathology input and speech therapy. But before we talk about those things, I want to take a step back and explain the terms language, communication, and speech. So I hope this isn't too basic for people, but isn't coming up here. Next slide. Yeah, sorry. Bit of technical problem, sorry. Great, okay, you're good to go. Yeah, terrific. Oh, great.
That's what they see. That's what
okay. Thank you. Sorry, people. Okay, so speech is produced by highly coordinated movements of the lips, mouth, tongue, vocal cords, and respiratory system. Speech can be impacted by damage to those actual muscles or the parts of the brain responsible for controlling the nerves and muscles. Language. Language are the words and sentences, reading and writing. I like to think of it as a two-way system, in and out. So input, we've got comprehension and understanding, and output being our expression. Expression and comprehension are processed in different parts of the brain, but obviously need to be connected. They can be impacted differently though, which is important to know because some people might have a strength in one other than another. So for example, they might be better at comprehending than expressing. Lastly, communication. So that's broader than language alone, and it really encompasses the social aspects and how we interact with others, as well as non-verbal behaviour, such as body language, gesture, eye contact, tone of voice. And I like to think of communication as being, well, an example is you can communicate with someone where you don't share the same language as them. So how does it work? Well, our thinking skills initiate an idea which is converted into words, which is structured into a grammatically sound sentence, the right nouns and verbs, etc. And these words are converted into the right sounds in the correct order and then organised by a motor speech program that executes the muscle movements responsible for speech. Now, whilst all that's happening, you're monitoring the responses of the person that you're talking with to make sure that they're engaged and listening. So as you can see, and I think it's really important to know that communication is a really highly complex skill. Now, there's last 2 points I want to make about normal communication. Firstly, that communication is collaborative. So if it's not reciprocated, that can feel quite personal. It's also very natural to feel awkward when communication breaks down. And this is an unconscious rule that we've learnt, that silence is uncomfortable, so we avoid it. But actually silence can be really important for people with communication impairments. So we've heard quite a bit about the symptoms of the different variants, and I'm just going to give a brief description of the types of speech, language and communication changes that can occur in the different variants of FTD and the impact of that difficulty for carers. It's really important to acknowledge, of course, that presentations are different, that they can vary, everybody is different. And also important to say that there can be an overlap between the subtypes as the disease progresses. So in behavioural variant FTD, there's changes in behaviour such as emotional blunting, apathy, disinhibition and social withdrawal. And that can result in, for people, difficulty generating speech, which means they just don't talk as much. Conversely, being disinhibited can result in people talking for extended periods of time without allowing other people to speak. Family members describe this difficulty with their significant other as not responding in the same way emotionally. In semantic variant FTD, there's a breakdown in the semantic system which is responsible for our understanding of how things work in the world. So that loss of semantic knowledge leads to difficulty in knowing and understanding words, including the names of people and places and objects. Errors can sometimes have a semantic or a meaning base. So for example, someone might say foot instead of shoe. And difficulties are evident with writing as well. Speech generally remains well articulated but can lack substance, so conversation might be a bit vague because of that word loss. People living with semantic variant might have significant difficulties understanding the speech of others because they've lost those meanings of words. Sometimes sentence level comprehension can be a bit better than single word comprehension though, because the whole context and more information within that sentence can sometimes be helpful. But as their understanding of the world reduces, people might become fixed on certain phrases or interests and routines. The impacts of these communication and language changes that carers report is a loss of intimacy and reduced reciprocal conversation where shared interests are lost. And this is really because people living with semantic variant FTD are having difficulty articulating their thoughts and ideas, having problem understanding and can't follow conversations as well. I'm going to mention logopenic PPA, even though it's language onset Alzheimer's disease, but it does people do present with language difficulties. And mostly the primary difficulty people are having with this variant is word finding difficulty because retrieving the word is difficult. And this often results in slow speech rate, frequent pauses while trying to find the word. So expression remains grammatically correct, but the speech might contain sound errors or phonological errors. So desk becomes dex or apple becomes papple. People with logopenic PPA can experience problems comprehending long and complex sentences, which presents as forgetfulness, but it's really because they haven't understood. Carers often describe their loved ones as talking less and experience reduced emotional intimacy. Apathy is common, which really presents as switching off from conversation, which carers report they find hurtful. People with non-fluent variant PPA present with non-fluent expression. So speech production might be slow and effortful, contain mispronunciations, and sometimes sound like stuttering. Sentence production might have grammatical errors as well. That speech production is associated with something called apraxia of speech, and it's a breakdown in that motor programming of speech. So someone might know the word that they want to say, but putting those sounds in the right order is disrupted. Comprehension of complex sentences is impaired, but single word comprehension is often spared. And writing might be relatively spared as well, and that's often used as a compensatory strategy. Apathy might be present later in the disease, which can result in social intimacy and shared conversation. As this variant progresses, it might declare itself to be a Parkinsonism condition. So, for example, cortical basal degeneration. And in these cases, people might experience increased difficulty with their motor systems and their movements, which leads to problems with their voice as well as their speech, and might involve problems with swallowing as well. So this is the perfect segue into talking about swallowing. And I just want to say that the medical term for swallowing problems is dysphagia. So swallowing is a really highly complex activity that requires planning and coordination of a number of different brain regions. Our eating and swallowing is monitored by our thinking skills, but enacted by a series of muscle movements and reflexes. When we swallow safely, food and drink passes past our airway, that's our voice box and larynx, or windpipe and trachea, and our lungs, and into the esophagus. But if swallowing safety is compromised because of muscle weakness, or poor coordination or cognitive difficulties, food and drink can enter the airway, causing coughing and choking. Choking is a life-threatening event because it prevents breathing. However, if food and drink regularly enters the airway and ends up in the lungs, pneumonia can occur, and this is called aspiration pneumonia. Aspiration is the medical term for food and drink entering the airway. And aspiration pneumonia can be serious. It can lead to hospitalisation and even death, which is why swallowing difficulties shouldn't be taken lightly. Other significant impacts of swallowing difficulties can be poor oral health, malnutrition and dehydration. So if you do observe these signs of dysphagia, coughing, choking, wet sounding voice, particularly with eating and drinking, please speak to your speech pathologist or ask your GP for referral to a speech pathologist. We have identified specific problems with eating and drinking or swallowing, particular to the different variants presentations, and Wendy touched on some of this. So, but I just will go through this briefly. So people with behavioural variant FTD, we see changes in eating behaviour because of the cognitive changes. So people might eat very quickly, they may not chew their food sufficiently, they might eat inappropriately. So for example, wanting a whole can of beetroot in one go. Dietary changes might be observed, particularly a preference for sweet food and drinks, or eating non-food items. In semantic variant FTD, those behavioural changes are also evident in eating and drinking, and people might only want to eat in a particular way, or eat particular types of food, for example, specific colours or textures, and we call that food faddism. They might want to eat their meals at a particular time in a specific way with specific utensils, and we call that mealtime rigidity. And also due to that loss of semantic knowledge, they might consume non-food items. We don't often see swallowing problems with a non-fluent variant or logopenic until later on in the disease. But with the Parkinsonian syndrome, swallowing difficulties are more common because of the impaired motor system, muscle weakness and cognitive difficulties. And so an oral and dysphagia might be exacerbated by those cognitive difficulties or lack of insight. So I've got here some safe swallow strategies. It's really important to get personalised advice, but here's just some general things you might find helpful. So if swallowing is particularly unsafe, speech pathologists might recommend modifying food and fluids, so really changing the consistency of what people are consuming. Some general advice though, reducing distractions, so not having the TV on during meal times. Offering finger food if utensils are becoming difficult for someone to manage. Simplifying the environment, so avoiding offering lots of different options at one time or different sets of crockery or cutlery, just one course at a time. Obviously at home that's a little bit easier, but certainly in the hospital setting where people get a whole tray, get a tray with their whole meal set up, that's something that I often have to take into consideration. Routine might help, same time, same place, same cutlery. If someone's taking large mouthfuls and that's becoming problematic, often offering or using smaller spoons or cups might be a good way of circumnavigating that. There's a couple of foods that I like to call my problem consistencies, which tend to be dual consistency food and crumbly food. So dual consistency food where you have a solid and a liquid together, it's very difficult to manage from a coordination point of view. And loose or crumbly food, it's quite easy for people to breathe in. So being extra careful with those. Tablets, that's really a dual consistency where you're trying to manage a solid and a liquid together. Lots of people have trouble with their tablets. So trying to have a tablet with something where it can all go down in one go. So a teaspoon of yogurt or a little bit of banana, a teaspoon of jam, that sort of thing. Just to provide some general communication strategies. So again, these need to be individual and they might change as disease progresses. There's some really good communication resources on the web, but also your speech pathologist will be able to provide that individual advice. But for everybody, not just people living with FTD, but for carers, ensuring your hearing and vision is corrected as much as able. The older we get, we know that those things can be problematic. Having good sleep. Being tired is not conducive to good communication. Allowing extra time for communication. It's complicated, it can take longer. Removing distractions, background noise can be very helpful. And I think a nice rule of thumb is to show more and talk less. But really importantly, and my lovely colleague that I work with, another speech pathologist, Mark Posibon, has taught me to know the person the dementia has. So really being, knowing what you know about that person, how they like information explained and presented, and respecting them for who they are or who they were. So to finish up, I wanted to talk briefly about speech pathology intervention and speech therapy, because I thought, and I hope I'm right, that you'd like to know about treatment. So early referral to speech pathology can be great assistance in tailoring communication strategies for people with communication impairments, and also for caregivers. The focus of treatment will vary, of course, according to individual needs. It won't provide a cure, but it will provide support. So what we know from the research that's been conducted with people with PPA around impairment-based therapy, so this is specifically word retrieval treatments, they can be effective. It usually involves reading and repeating a set of words. The research that's been done has been intensive therapy, daily with a clinician plus daily homework, and results have been shown to be effective during those studies. We just don't know at the moment how well it generalises to everyday conversation and other words, or how long those benefits last for. Another impairment-based therapy is script training, where people learn a variety of scripts with the aim that they can then use those sentences in conversation. Again, it's intensive and it has been seen to have lasting effect, but mostly for people with motor speech problems and improving grammar. This is really targeting people with non-fluent variant PPA. So another approach, and it's not just specific to PPA, but is compensatory-based therapy. There's limited research in this area, but it is actually commonly practiced. And mostly the intervention focuses on implementation of supportive strategies to compensate for difficulties, such as alternative communication aids, picture boards or communication devices, gesture and non-verbal communication. We know that group education is beneficial. People living with PPA and their families report the benefits of sharing strategies and receiving information in that way. There's also some nice evidence for communication partner training, where we train family members or close friends so they understand how to better communicate with people living with dementia or communication impairments more effectively. What we also know about speech therapy is, there's benefits and barriers. So certainly the research shows us that quality of life can be improved through speech therapy. Some of the barriers to successful speech pathology intervention is when someone doesn't have any family or carers to be involved, or if the carer isn't motivated to help with that therapy. It's also challenging if the person with the communication difficulties doesn't have any insight into their difficulties, or they're not motivated to participate. Unfortunately, we know too that there's some barriers here in Australia and also overseas to accessing that intensive therapy. In the public system, it's primarily due to insufficient funding. Very few public services have the ability to provide that intensive therapy. And in the private system, it's that cost-intensive treatment the cost of that can be prohibitive. So thank you. I hope I've kept to time. That's all I wanted to cover. We might have some time for questions. And I'm just going to flick the slide to just for some other communication strategies while we chat.
Hi Camille, thank you so much for that. We do have one question from the audience here. If FTD can include swallowing difficulties, might it also include issues with the sphincter muscle of the esophagus causing reflux?
Oh, good question. Generally, reflux isn't about that sphincter muscle. That sphincter muscle is controlled by the sort of complex mechanisms in the brain, and so generally reflux is more to do with, is a separate condition. So sorry, Claire, could you just read the question again for me?
Yep, no worries, Camille. So Dorita just wondered whether, because there's swallowing difficulties in FTD, whether there might also be difficulties with the muscles of the throat causing reflux.
Okay, sorry. So there might be some reflux related to dysphagia, not necessarily due to that sphincter muscle. In my experience, people can have reflux without having any swallowing problems, and not everybody with swallowing problems will have reflux.
Great, thank you, Camille. Well, that's all the time we have time that we have questions for. So we'll move on to the next talk.
Okay, thank you, Claire. I have the great pleasure to introduce two of my colleagues, Dana Fail and Dr. Samantha Loy. Dana's the social worker here at Neuropsychiatry, Royal Melbourne Hospital, and she works across the inpatients and the outpatient teams. She's got a strong interest in family work and is currently completing her Masters in Family Therapy and Systems Therapy. Dr. Sam Loy is a neuropsychiatrist and Senior Research Fellow at the Royal Melbourne Hospital and the University of Melbourne, as well as working with older and younger people with dementia. She is a strong advocate for carers and has completed her PhD investigating factors associated with depression in older carers. She's currently researching the psychosocial outcomes of people with younger onset dementia and their carers as they traverse their pathways to diagnosis and ongoing management. Thank you. Hi everybody, my name's Dana. I'm the social worker, as Camille said. I'm going to talk a little bit about carers, as opposed to, we've been speaking a lot about people with frontotemporal dementia, and I really want to try and reach out to people in the audience that are actually doing the caring role. But also wanting to acknowledge that you guys are, of course, the experts rather than us, but that as healthcare professionals, we sort of try to understand what you are trying to manage at home, particularly in these current circumstances of this year and the COVID-19 pandemic. I just want to talk about some of the positives, and I understand that these are the things that people will often tell you, oh, it must be very important to you, you must be very rewarding, and I'm sure that there is. So we'll just talk a little bit about these first. So it's you have an opportunity for personal growth, new skills, strengthening the relationship of the person that you care for. It's very, very challenging. You can meet new challenges and achieve new challenges, and you might get some satisfaction in knowing that you've contributed to improving the quality of someone's life. But we also know there are many challenges in this. One of them is that, of course, it's demanding and restrictive on your life and the person that you're caring for. The financial hardship of being a carer. 50% of primary carers in Australia are on a low income, and many can find it hard to cover living expenses, save money, and build up super, which makes life very, very difficult moving forward. Caring can be very emotionally taxing, physically draining, and they have the lowest wellbeing of any large group measured by the Australian Unity Wellbeing Index. So it's really important to keep in mind your own health and wellbeing in these situations. Carers often ignore their own health and are 40% more likely to suffer from a chronic health condition, such as back problems, anxiety, and depression. Many carers are chronically tired and desperately need to refresh with just a night of unbroken sleep, a day off, or a period of time with no caring responsibilities can actually be life-changing, feel like it's life-changing. And the other disadvantages of being a full-time carer is that you miss out on your own opportunities, such as work, building your own career, a lack of freedom and spontaneity, and a general enjoyment of life. There's a lot of talk from health professionals when we speak to carers about carer burnout, carer stress, carer burden. You may not even realise that it's happening to you. I guess the definition of it is that it is a state of physical, emotional and mental exhaustion, accompanied by a change in attitude from generally being positive about caring to appearing negative and unconcerned. But there's many stages in between that. I've got a little slide here about the difference between stress and burnout. It's a little bit fuzzy, so I hope you can see it. So you can see on the left, there's symptoms of carer stress versus carer burnout. It doesn't really matter per se, but I guess if you're starting to feel more the symptoms on the right, then it might be time to have to engage in some help, or just have a break, or just think about yourself for a little bit. So why do you guys feel carer stress or carer burden? Because you're often so busy caring about someone else as well as juggling your own life that it can become easy to neglect your emotional, physical and spiritual health. It's particularly relevant when the onset of illness happens earlier in life, as it can do with frontotemporal dementia. And we all know that life doesn't stop around you when you are a carer. So you may have children, trying to juggle work, trying to juggle a whole lot of other things in your life. And we all know we can't stop any of that. These demands on your body, mind and spirit can be overwhelming and can lead to fatigue and hopelessness. Some other factors that might come into play are some role confusion. So you might feel some stress about thinking at one point I may be a partner, now I'm a carer, where do I sit along that spectrum? The same with once I was a daughter, now I'm a carer. That can become overwhelming in someone's mind. It's important not to have unrealistic expectations on yourself, to provide all aspects of emotional and physical care and leaving a little bit of something for yourself. Lack of control over the progression of a disease, of caring resources, and the lack of control of how you thought your life may turn out, and the difference in those pictures can also cause a lot of stress. The other thing to keep in your mind is unreasonable demands, and these can come from the person that you're caring for, from the healthcare system, from service providers, from your own workplaces and from other family members, and this can have a huge impact on how you're feeling. We know as healthcare providers that we often ask carers to do a lot, and we realise that, but sometimes it's, we try and pull in other services to fill that gap, but we also know that we put a huge amount of burden on carers. When does carer burnout occur? When you don't get the help that you need, when you're doing more than you're physically able to, and if you start feeling guilty or indulgent if you're spending time on yourselves, lack of resources, frustration in accessing services, and that feeling as a carer that you aren't good enough or inadequate if you actually ask for help can lead you down that track to some burnout. I've just got a few symptoms of carer burnout on the screen here. Obviously a whole lot that may be individual to you and your situation. So withdrawal from friends and loved ones. You may not feel like you've got anything to contribute anymore, or that you may be talking about the same things. Loss of interest in your usual activity, changes in sleep and appetite, that feeling of feeling blue and hopeless and helpless, becoming sick more often, becoming irritable more often. Some of these symptoms are actually similar to depression and could actually manifest in you requiring some of your own clinical treatment, and I think it's important to be aware of these. I just wanted to talk a little bit about emotions and caregiving. Whether you're at the beginning of your journey or in the middle or towards the end, there's going to be a whole lot of emotions that come up for you as individuals, and I think it's important that they're validated and that some of this does become about you and not just about the person that you're caring for. And it's hard for some of these to admit some of these feelings for fear of being judged or not wanting to burden other people. I should have a little, yes, so these feelings include ambivalence of sometimes wanting to be the carer and sometimes not wanting to be the carer, and there's good and bad days. And I think acknowledging both sets of these feelings, knowing that hopefully neither of them will last forever. Anger, losing your cool, having frayed nerves are a normal part of being around someone who requires help on an ongoing basis and who also may not be accepting of that help. Anxiety is another common feeling of being a caregiver, and that's feeling like things are becoming out of control and not knowing how to bring those things back under control. Boredom is something that we can probably all relate to at the moment, not just the caregivers. A feeling of being stuck at home, the same routine, too tired or busy to pursue your own interests. Irritability, I don't have that up there, but I'll mention it. Lashing out because you've got little or no reserve because you're just exhausted. Depression and sadness, feeling hopeless, helpless, finding it hard to start the day, crying more than what you would ever cry. Loneliness, becoming isolated, losing a sense of yourself. Friends may stop calling you since you're not as available, and you may hesitate to call them because you think that they might not want to hear about your things anymore. Loss, and I think Morelle's going to talk a lot more about loss towards the end. Loss of control, loss of your own independence, loss of your best friend or your partner or your parent, and a loss of the life that you imagined that you may have had. Resentment, you may feel unappreciated or unacknowledged by those around you, and you may feel like you're the only one providing care, and this can bring a sense of resentment. Tired, impatience, frustration. Jealousy, you might start feeling jealous of friends and family who can go out and do things that you can no longer do, or jealous of siblings that aren't helping you care for your parent, that sort of thing. Disgust and embarrassment is something that we don't really talk about a lot, but I think it's important to acknowledge that if your person that you're caring for is eating sloppily or making embarrassing comments, further down the journey you may have to help out with some personal care. It's completely normal to feel some uncomfortable emotions about this, and it's important to acknowledge them. Fear about what's going to happen in my life. Am I going to be able to cope? Am I responsible for things that go wrong? Scaring yourself with questions of what ifs can be paralyzing, and sometimes it might be easier to start trying to shift that what if to concentrating on what's happening now. Grief, Morelle will speak a little bit about that, and guilt is a very interesting feeling, and I think sometimes it's important to reframe guilt as the goodness in you sort of trying to come out. The guilt from feeling what you haven't done enough, or wanting the situation to end, or guilty from feeling impatient, or guilty from feeling disgusted, or guilty from feeling resentment, or guilt for thinking about your own needs above the person that you're caring for. They're all quite powerful, and I think it's really important to acknowledge them all. I've got a little, sometimes as healthcare workers, we often give carers lots of advice, which can be very overwhelming, and sometimes you might walk away thinking, how am I going to do this all? So I thought that this lady sort of represented a bazillion little pieces of information that you might walk away with, but I wanted to try and talk about some strategies that might actually be more helpful. So what actually can help is identifying and acknowledging feelings. That can be a great source of relief, and whether you do this with a friend or a professional is up to you, but I think even just talking about this stuff, the effect of this can't be underestimated. Forgiving yourself for feeling these things, keeping active. We all know about the benefits of exercise. Creating a support system, and what that support system is going to be individual to you, whether that's health professionals, friends, support groups, carers groups, online groups,
family, it's all going to be up to you and individual to what is going to suit your needs. Carers groups, I think Wendy and I will speak about that a bit later. Using respite when it's available to you, don't feel guilty about it. Sleeping, acknowledging yourself, pat yourself on the back. Just know that you're doing a good job, even if no one else is going to acknowledge you. Meditate, pray, breathe, whatever floats your boat in that way. I think it's very important. And have some awareness of self-care. I think I'm going to go on to Sam now. Hopefully Sam's talk is, there we go. I'll just put Sam on.
Thank you, Dana. I'm so glad you covered some of the topics which I am only going to talk a little bit about. So thank you for having me. And as Dana said, as a carer, you guys are the expert and we ask you to do a lot of things. And I guess I'm just going to give a bit of a narrative about the costs associated with caring. So I'll talk firstly about the financial costs and then talk about some of the emotional and psychosocial costs and some of the reasons behind this. So what does the research tell us about the financial cost of caring? The others have talked a little bit about this, but we do know that the caring for someone, looking after someone with FTD is almost twice as much as that with Alzheimer's dementia. And it's likely to be due to the younger onset of the disease. It's often occurring at the peak of one's earning capacity for both the carer and the person living with FTD. So these costs relate to a decrease in the household income, early departure from the workforce, with only a small number of people with FTD who are still in paid employment. And how about the carers? So because it's a younger onset disease, almost 75% of people of carers are still working full time, but they may miss out on or reject promotions and increased responsibilities for their work and career progression due to their caring role and perhaps missing days of work. Now, these days at work might be missed because they're actually attending appointments with the person with FTD. They're having to take a day off because they're worried about leaving that person alone, but also days off for themselves. So maybe attending appointments, also from the stress or the tiredness, which Dana alluded to. So whilst younger carers tend to be more robust and have better physical health, many of them report a notable decrease in their physical health. They talk about back pain, neck pain, insomnia, lack of energy and headaches, as well as the anxiety and depression. And of the different FTDs, BVFTD, the behavioural variant, is thought to have the most costs. And this possibly could be related to things such as poor decision making, so poor financial decisions, being involved in scams and gambling and other type of legal issues. So how about the emotional and psychosocial costs? So I'm just going to talk a little bit about why this might be and perhaps offer some solutions. So Alzheimer's disease is much more well known than FTD, but it's very different. Public understanding of dementia is largely based on knowledge about Alzheimer's dementia and often an older onset Alzheimer's disease. And there are distinct differences in caring for someone with an older onset Alzheimer's disease and a younger onset Alzheimer's disease. And then you add FTD into the mix and it's vastly different. You can't assume that the issues that a carer who's looking after someone with Alzheimer's disease are the same for a carer who's looking after someone with FTD. But often the resources and the services available are geared towards older adults with Alzheimer's disease and thus may be inappropriate or irrelevant for carers of someone living with FTD. For example, support groups, education sessions might be scheduled during business hours when you might be working, so you can't really attend. Activities for the person with dementia might be bingo or bridge. Again, not really appropriate for a younger person. And I won't even start at aged care facilities and why they are inappropriate for someone with FTD. So it's not surprising that as families looking after someone living with FTD, you might be quite dissatisfied with the information given about disease, the available services and the support. You might be worried that your GP or your specialist may not be an expert or have the experience in treating someone with FTD. So there are similarities though as a carer with someone who's caring for a different dementia or an older onset dementia, often female, the spouse, looking after children, but there are quite a lot of differences. And some of the differences people have looked at are the different types of behaviours and what might be more difficult, and particularly for the behavioural variant FTD. So in Alzheimer's disease, the memory problems often come first. In FTD, it's less obvious. So the behaviour and the personality changes might be mistaken as depression or stress. So you might be even less inclined to think that's actually dementia. So that's one thing. But what carers have reported that it's apathy and the passive behaviour, which is really difficult. So the constant nagging and forcing someone to do what might be the most simplest of tasks, such as getting off the couch, is really difficult. So the constant pushing and pushing and pushing, and that ties in with the different roles. So I'm no longer the spouse or the partner, I'm now like the parent. The socially embarrassing behaviours is also tough. So how do you keep brushing off comments or making excuses when your loved one says things like, oh, you must be getting fat, or you're looking not very nice today? How do you keep pushing and keep on going with that? But as a clinician, as a psychiatrist, one of the problems I think which are really difficult is the isolation which carers experience. So it's not just isolation from friends and families because you have no time, but it's a combination of the lack of insight and lack of empathy and understanding from the person you're caring with FTD. So there's a loss of friendship and shared understanding and feelings. This could be due to, as Camille talked about, not being able to communicate, so the language problems, or just by the FTD itself. So carers I've talked to said they never expected to be dealing with this by themselves. They can't talk to their partner anymore. They can't talk through the decisions together. They can't share the experiences. And it's the fact that the person they're caring for doesn't seem to care or appreciate what's being done for them. And that's really tough. So the decline and the eventual loss of capacities and emotional engagement, which is one of the most sustaining and human in a mutual relationship, is devastating. And that's what I find really difficult for carers in FTD. So how do you find a way to understand, continue with and cope with the thankless and non-reciprocated tasks of caregiving? How do you face the future, knowing that the person you're looking after is going to get worse and they are going to not have an awareness of what you're doing and that you're doing it for them? So what are some of the solutions? So first of all, there's the stigma of people not understanding what FTD is. People know what Alzheimer's is, and when people hear the word dementia, they almost automatically think of Alzheimer's. There's the Alzheimer's Day, there's the Alzheimer's Walk, there's Alzheimer's this and that. And that's why groups like this are really important to raise awareness. There are also specific support groups for FTD, and they're at appropriate hours, they're in a flexible manner, so get involved if you can. As clinicians, being aware of FTD and how it might present is really important to improve assessment and reduce the diagnostic delay. And post-diagnosis, being able to easily access services such as in-home care, appropriate day centres and activities for a young, healthy person who will potentially have embarrassing or inappropriate behaviours is crucial. Now, Dana talked a lot about this, and I would really agree, but I know it's hard. So having time out for yourself is really important. You might feel guilty about not being there 24 hours a day, but you need to have a break. So not only is easier and improved access to community services is really important, but having appropriate activities and paid carers who are educated about FTD, so they know what to expect, is also crucial. Another practicality which I have experienced is having a much smoother path to financial, to improve your financial situation. So I talked a little bit about the costs, and Dana talked about this as well, but accessing super and insurance is a nightmare. So because you have a dementia, because it's young, it's less common, so they appear to be more hoops to jump through, more forms to fill, and it's overwhelming. So not only do you have to battle filling in forms, making phone calls, you're supposed to work, you're looking after the person, you've got children, it's really difficult. And these are some of the tasks having a social worker or a case manager to help you with would be really important. One of the last things I would recommend, that as a carer, you find a support person. So whether that is a counsellor, a psychologist, a paid person, or a friend. But someone for you. So someone you can check in and talk with about you. And it's all about yourself and how you're going, so you can keep continuing to do what you're doing as long as you want to. And someone who is going to go through the journey with you. A carer is often thought to be the forgotten patient, and it's essential that we remember who you are. Thank you.
Thank you so much, Sam and Dana. That was an excellent talk. We do have time for one question. There was just a question about whether you could give some advice on when is a good time to consider residential care.
Do you want to start?
I'll start. There is no specific timeline that I would say to consider residential care. It really is up to the individual, which I know can be quite an annoying answer because people really want some structure around this. And some people can continue caring for someone way before someone else may feel comfortable with it, depending on what's going on with their life. A lot of people start to consider, in my experience, a lot of people start to consider residential care around the time when issues of personal care become difficult to manage, in terms of the person receiving care may start to feel uncomfortable about their partner providing personal care, toileting, continence issues, those sort of things, or when the carer can't manage it anymore. And they might start with a little bit of respite and build up to find so that that person feels comfortable in that chosen residential care, and they may slowly move towards then. But it really does depend on what's going on in someone's life and what they're able to manage, and issues of aggression may come into play, particularly if there's younger children around. I think it's really what's going on for the individual.
I'll add to that. As part of my regular discussions, I try to introduce the thought of respite early on. So I agree with Dana about the personal care. That's when things start getting quite different, and that's when there's often a trigger to residential care. But sometimes getting into the habit of thinking about the person going into respite, that helps the person with the dementia, and also as the carer to get used to that this person is going somewhere regularly in a place where they hopefully will get to be known by the staff, and we all feel comfortable that this person is having a bit of a break for themselves, and as a carer you're getting a bit of a break for yourself. And so if this, in an ideal world, starts happening on a regular basis, then it becomes less of a transition when you think about longer stints and then permanent care. So I think getting in early and trying to introduce this often really difficult topic, because I know there's a lot of rejection and, oh, you're abandoning me and you can't cope, that's hard. But thinking about coming to a decision together, I think is useful.
One piece of advice I might just add in is with respite, this is a very common problem and I see it all the time. If you can, an idea if you want to try respite is to book it well in advance.
Regularly.
If you want to try it regularly, you can do it regularly, but just to book it well in advance, depending on how comfortable you are with it, because you don't want to start having to access respite if there's an emergency. So if you break your leg or something happens to you, or you have your own healthcare emergency, that's when respite can be difficult to access, because it does require a bit of planning, and you may want to look around to find a facility that is that suits you. In an emergency, you aren't guaranteed that you'll find a facility that suits you, and you may end up having to go very far away from where you live, or having to pay more money than what you had hoped to. So that would be my thinking about respite, would be plan ahead.
Yeah, I would agree with that, because then if you know that in 3 months' time or 4 months' time you're going to have a week or 2 weeks off, that helps you get through the period of time. And then everyone knows that it's coming, it's prepared, everyone's in control, and there's no sort of reactive or knee-jerk reaction if something's happening. It's, oh no, you know, my loved one is going into care for 2 weeks for a bit of a break, I get a break, and hopefully that is a smoother transition.
Are we going to play a video now? I'll just let Wendy have a chat.
Great, thank you for that excellent advice, Sam and Dana. That's all we have for now.
Hi everyone, we're multitasking in the room at the moment. So I'm going to play a video now and I'm just going to introduce David, who's in the video. So David is in his 60s and he's the primary carer for his wife, Susie, who was diagnosed with semantic dementia in 2012. So in this video, David's reflecting on his journey with Susie, looking after her and about some of the challenges that COVID has brought and looking at his future ahead. Susie was placed in care in 2019, so has only recently entered into residential care. He talks about some of the challenges that has brought. To be interviewed today. Can you tell me a little bit about your story?
Yeah, thanks, Wendy. Dave is my name, obviously. I've been looking after my wife, Susie. She got diagnosed with frontotemporal dementia semantic variant, or primary progressive aphasia, I think it can be called at times. She got diagnosed in 2012, but she did get tested in 2011. But they weren't sure then. And subsequent to that, I found out that she had a CAT scan on her brain in 2007, which she didn't tell me about. The first symptoms of it were probably now in hindsight, you look back at what was going on then, and you sort of realise that she was having trouble saying words or even typing, particularly, you know. Plus also she was, so just a bit about Susie's background is that she she founded the chocolate tours in Melbourne in 1993. And I remember once she told me that she got sort of stuck in a place in Melbourne called the Black Arcade. She'd been there umpteen times before and she couldn't remember the name of it. And also she was also a volunteer guide at the National Gallery and she loved art. But she found it more and more difficult to study the special exhibitions. And I was really surprised in 2010 when she quit, because I knew she loved it. But these were things you saw now in hindsight was happening to her. And through sort of all of this, she became more anxious and all she wanted was a cure. I probably should go into the fact that, you know, Susie always felt that her body carried her personality, and so therefore that's why she was such a good talker. But she became more anxious, and in 2015 she attempted a drug overdose twice because she didn't want to end up like she is now. So she got put into hospital then, and sorry, I try and compose myself. But out of that came some good, in as much that because they wouldn't let her home until we had got her less anxious, we got onto a transition care package, and through that we came all facilities and home care packages. So that was the only good thing that came out of that. But you know, I think I've said to you before, we all know what's going to happen, but the reality of it happening is confronting.
Yeah, absolutely. And I think we've talked before, David, haven't we, about intellectually knowing it's going to happen, but then the emotional, when it actually does happen, the heart, you know, the head, that disconnection.
I always say I've got a twin brother. I've got the logical twin and I've got the emotional twin.
Absolutely, yeah.
My advice to anyone is, look, it is all about hope, but we all know there's not a lot of hope. You know, we hope one day, and that's why I go. You know, I still like to be in touch with the Frontier group. I hope one day research will come up and stop this progression. But also you've got to have support of people who understand what you go through. And I must say, so that's why sadly, you've got to mix with people that know what you're going through. I think the other thing was, other really good piece of advice I got, particularly when Susie was in the, when she got sectioned under the Mental Health Act, I just wanted to bring her home. And I said to them at the time, you know, I'm only in my 60s. I'll give up work. I'll bring her home. And they said, no, don't give up anything. Don't give up anything. I think it's really important that the carer keeps a life for themselves. And I've had to give up a couple of things, but there are some things, as you know, my Art Deco Society that I'm still involved in. I still work a couple of days a week. I go to the football, I watch the horse racing, I go there. I've kept things interest so that now Susie's not at home, I don't have this massive vacuum. I've got things, not at the moment because I can't go anywhere, but generally speaking, so you've got to have you've got to also make sure you don't give up your life completely, because there is a life afterwards. I mean, I think we've spoken before that one of the aspects is that I do worry about my future. I'm sort of young enough, you know, our lives wasn't going to end up like this. You know, we're in our 60s, we're going to enjoy our retirement. Well, that's not going to happen together. So what's my future going to be? And that's probably one of my anxious moments at the moment, of what I do next.
Yeah, thanks so much, David. We have spoken before about how important it is still to have the essence of yourself. I mean, there's a couple of roles that you are in at the moment. There's just you as David. There's you, David, you know, Susie's husband, and then there's you as Susie's carer. That makes sense.
Yeah. Yeah.
And what does, I think we've discussed before, what does the future look like? And I know that that can be quite daunting as well, when you spend so much time, you know, loving and caring for someone. Planning that's quite hard when you don't know what the future holds. Yeah. Thanks, everyone. I'd just like to thank Dana and Sam as well for their excellent talks about caring. And Dana's going to speak in a little while as well, just about particular supports that are out in the community. So the next thing I'd like to do is introduce Morel. So Morel is a psychologist and a research assistant with the Frontier Research Group at the Brain and Mind Centre at the University of Sydney. And she works directly with FTD caregivers in performing assessments and in providing education and ongoing psychosocial support throughout the dementia journey. So today, Morel is going to talk about grief and loss in frontotemporal dementia. Thanks so much, Morel.
Thanks, Wendy.
Sorry, while Morel's sorting out some technical difficulties from her end, I just wanted to reassure everyone that this webinar is being recorded and the presentations and selections of the video recording will be available on the World FTD United website as we go along. And if you have questions, please type them in the question box and we'll answer as many as we can. And if you have any technical difficulties, if you lose vision or sound, please log out and then log in using the original email that you were sent. Thank you. I'll hand over to Morel now.
Sorry, everyone. Sorry for those technical difficulties. So thanks, Wendy, for the introduction. I'm going to be presenting on grief and loss in frontotemporal dementia. Sorry, it's a little bit laggy.
She's there on her own.
Hi everyone. Just while Morel sorts out the technical difficulties, I think what we might do is have a couple of minute break for people to quickly get a snack and go to the bathroom, and then we'll resume in a couple of minutes time. Thanks everyone.
Okay, sorry everyone. So take 3. So to begin, it's not working again.
Hi, Mirelle, it's Dharma here. Just to quickly let you know, we're seeing your presenter view. Is that okay, or do you want to? We've lost her webcam.
Okay, everyone, let's see how this goes, but I'll do the best that I can, but we're having a few technical difficulties. So to begin, I wanted to show you some artwork that depicts grief in FTD. And these are two paintings by an American artist named Tori Tinsley, who cares for her mother who has FTD. And the painting on the left shows Tori reaching towards her mother, who looks away without reaching back. And the painting on the right depicts Tori hugging her mother as she slowly slips away. So I chose both these paintings because they really typify the experience of grief in FTD and represent that very deep sense of yearning and longing for someone who is alive, but who is also slipping away. So, in order to understand grief in FTD, we first need to look at how grief presents typically. Grief is a psychological response that we experience when we are faced with a significant loss. And we typically think of grief in the context of physical loss, such as death. Sorry. Such as death. But grief can occur following a variety of other losses, such as the loss of a relationship, the loss of a job, and perhaps one that we can all relate to more recently is the loss of normality during the coronavirus pandemic. So when we're faced with a significant loss, we first experience what is called acute grief. And acute grief is that initial emotional distress that occurs in the early stages of the loss. And that's when the emotions of grief are all encompassing and they really occupy your mind all the time. So that acute grief then eventually transforms into what's called integrated grief, which what that means is over time, we adapt to the loss and potentially gain a sense of closure, and we're able to regain a lot of the functioning that might have been lost during those acute stages. Now, the process of grief doesn't unfold as neatly in dementia. So in dementia, grief is a process that begins before physical death. So this is called pre-death grief or dementia grief. And it is an experience that is unique to dementia carers and their families. And whilst post-death grief is also an issue for caregivers, I'll mainly be focusing on pre-death grief in this presentation because of how unique and intertwined it is with dementia caregiving. So let's have a closer look at what characterises dementia grief. So dementia grief is a form of anticipatory grief, which is when you're expecting someone to pass away. And it involves progressive losses that are ambiguous and that also vary in magnitude. So some losses are considered to be bigger than others. And whilst we see this very particular type of grief, anticipatory grief, in the context of other terminal diseases, such as cancer, it is very different to dementia grief, because in dementia, the carer and the family has to contend with what is basically the essential parts of the person, such as their cognitive skills, self-awareness, personality, and character. And these losses are particularly devastating because they impair opportunity for connection, communication, the sharing of memories and conversations, all things which are possible to do in any other situation where there's an impending death. And this is even more so the case with FTD, where the early symptoms are a change in personality and character. So there's also a very well-established relationship between depression and grief in dementia caregivers. And although pre-death grief and depression are linked, they're also very different in their presentations. So some examples of the symptoms of pre-death grief include things like yearning, longing, separation, distress, and these types of symptoms can look like depression, but actually they are part of a grief reaction. And it's important that the symptoms of these two things are distinguished, because, especially early on, because they have implications for the kind of support and intervention that is provided to the caregiver and to the family. So if we look at the literature more closely, there's also, numerous studies have also found that pre-death grief increases at particular time points. So it tends to increase when the dementia advances, as the caregiver's own health deteriorates, as caregiver burden increases, and whilst the carer makes plans for nursing home placement, and then at the time of nursing home placement. There is also an association between pre-death grief and post-death complicated grief. So complicated grief is that kind of prolonged, unresolved grief after death. And a couple of studies have shown that greater pre-death grief during life is a key predictor of post-death complicated grief in dementia caregivers. And approximately 20% of dementia caregivers will experience this prolonged complicated grief following death. So what does all of this tell us? It tells us that in dementia, grief is not just a standalone symptom, it's an overarching process that can begin at any time point during the disease process, anywhere from diagnosis to the very late stages of dementia. And in FTD, this grief process may come about earlier than in other dementias, simply because of the nature of the early losses and the course that the disease takes. So the literature also shows us that there are potentially different grief reactions in adult children caregivers and spousal caregivers, which also vary at the different dementia stages. And as you can see in this table here, it seems to be that the biggest differences in grief reactions between adult children and spousal caregivers occurs in the mild to moderate stages of dementia. So you can see that there's an array of emotions that are felt, but perhaps there's slightly more acceptance with the spousal caregivers and more focus on maintaining the relationship in the spousal caregivers. Another important finding from the grief literature is the factors that are associated with grief severity. And from this slide, you can see that it seems to be that certain helpful and certain unhelpful coping strategies, along with other situational factors, impact the severity of grief. So things like adaptation of the caregiver to the current situation, acceptance of the losses, pre-morbid marriage and satisfaction, they're all things that are associated with lower grief severity. And then you see things like avoidant coping mechanisms, self-blame, and expectation to institutionalize are all associated with greater severity of grief. So we've looked at a few of the characteristics of dementia grief, but now I want to actually show you a theoretical model of grief. And unfortunately, there's no specific theoretical models of grief in FTD that has been described in the literature, but I'm going to show you a model which characterises dementia grief as this evolving process that impacts caregiver burden and distress. And this model is called the dementia grief model. And in the dementia grief model, grief is said to cycle between 3 states: separation, liminality, and re-emergence. And within these 3 states, there are mechanisms, which is in the blue writing. These mechanisms function to facilitate grief and to basically move the person through the grief process. And conversely, there are barriers in each state. So those are the ones in red, and they prevent movement through the grief process. And before we go any further, I just wanted to say as well that this grief process is considered to be normal and healthy within the context of dementia caregiving. So this is a process that is meant to happen. So let's have a look at the first state. The first state is one of separation. And separation from the person with dementia begins before physical death, as we know, through a series of what's called compounded serial losses. So what that means is that over the disease course, over time, the number of symptoms, like the ones I've listed there, and therefore losses, increases and intensifies. So in FTD, some of the early losses include the meaning of words, speech, motivation, empathy, inhibitory control. And these losses are unique to FTD, and they aren't typically seen in the early stages of other dementias like Alzheimer's disease. So these losses, these early losses then progress to more advanced losses, which is where the person's functional ability starts to decline. And carers also describe a series of more intangible losses. So the loss of future plans in spouses, the loss of a romantic partner, the loss of marital life, and even things like the loss of personal freedom and the loss of control. And each of these losses progressively leads to a separation from the person with FTD. So the more losses, the more sense of separation that is felt. Now, the mechanism which is in this state is acknowledgement of each loss. And without the first step of acknowledgement, there is no graduation towards adapting to the circumstance that the carer is in, or even to the reality of the loss. And I say this quite easily, but I also understand that acknowledging these losses can be really, really challenging because the losses are unpredictable, they're largely irresolvable, and they can occur at a really fast rate as well. So, for example, a person with FTD can lose the ability to cook, drive, and be left alone all within the span of a few months. So the next state is called liminality. And liminality refers to being in between a previous situation and a new emerging situation. And in dementia, in this grief process, it is considered necessary to transition between the old situation and into the new situation. And I just want to point out that there is a very difficult but crucial transition that occurs early on from the pre-diagnostic stage, where the carer is in this state of sort of searching for reasons for the behavioural changes that are happening, to then transitioning to this kind of new situation where they sort of have to live with the reality that all these changes are occurring due to this condition called FTD, for which there is no cure and for which they don't know how much time they have left as well. Another very difficult aspect of the liminal state is coming to terms with how ambiguous some of the losses are. And this ambiguity is considered to be, by many, to be the defining characteristic of grief in FTD. So when someone is diagnosed with FTD, there is no post-diagnostic roadmap that they can follow. There's no formally defined or widely accepted stages of FTD, despite all the research. And there's no timeline either. And carers have to contend with the fact that FTD is ultimately terminal, but its course can run anywhere from 2 to 20 years. So there's lots of unknowns and there's lots of grey areas. And I think one of the most ambiguous and profound changes that happens in FTD is the loss of self. And what I mean by that is the deterioration of personality and identity, such that the person slowly becomes psychologically inaccessible. And this is particularly the case with behavioural variant FTD, where the person will eventually express themselves as though they're someone else or someone new, or at least not who they used to be. And this is really hard to comprehend, especially for carers and for family members, because the person that they look after doesn't act like the person that they once knew, but they are the same person. So in other words, what I'm trying to say is that the person with dementia is physically present, but they're also psychologically absent. And the mechanism in this state is opening up to and tolerating difficult feelings, whether it's sadness, anger, frustration, guilt, resentment, or even hope. Those emotions are neither good nor bad, they're just there to be felt. So now we move on to the last stage, which is called re-emergence. And think of this state as being one of acceptance. So acceptance of the losses that we had gone over before, acceptance of your own emotions, and acceptance of a new and different future. So the mechanism in this state that helps move the person through grief is what's called behavioural adaptation, which is more practical in nature. So some examples of behavioural adaptation include arranging care, putting in place power of attorney, taking over responsibilities previously held by the person with dementia. And for people who have language problems, learning things like new ways of communicating with the person with dementia. So I think this state is important because FTD is a disease where, and in fact all dementias are diseases where there is no clear resolution, and I think maybe adaptation is the closest that we can get to a resolution. And it is considered to be a sort of precursor to achieving any sense of closure and stability. And although there are many aspects of the person and indeed life that are grieved, carers often report this sense of newfound meaning through caregiving, and even this sense of post-traumatic growth. So to summarise, grief is a unique process, and it begins prior to physical death, as we know. So it can begin anywhere from diagnosis to even the late stages of dementia. We know that grief has characteristics of dementia grief has characteristics of many other types of grief, particularly anticipatory grief, but it can also have characteristics of traumatic grief and even disenfranchised grief. We know from the literature that dementia grief is associated with depression. It is expressed differently in adult children caregivers versus spousal caregivers, and the severity of the grief can be influenced by situational factors and also through by the way that carers cope with the grief. Sorry, the slides aren't working again. Okay, and just a few more points in the summary. So we know that pre-death grief is a predictor of post-death complicated grief, which means that perhaps there are some factors in that pre-death grief stage that we can modify to prevent post-death complicated grief. We know that dementia grief begins earlier and comes about in a more ambiguous way. Most importantly, grief in the context of dementia caregiving is a very normal and healthy response, and movement through the grief process that I had described may alleviate caregiver burden and stress. And finally, I would like to impart some practical tips for addressing dementia grief that are not only natural conclusions from the literature, but also from the lived experiences of FTD caregivers. So knowing that dementia grief happens earlier in the disease process, it may be a good idea to seek grief counselling early on. And we know that pre-death grief can prevent post-death complicated grief. Know that the feelings of grief aren't always easy to recognise, and they can be confused with depression. And so it's really important to try and differentiate between all the different things that you're feeling, whether it's grief, stress, anger, resentment, etc. Try and connect with the person with FTD in different kind of ways. There's many ways besides communication in which we can connect with each other. Remember that FTD is full of grey areas, and perhaps it's a matter of embracing that ambiguity and learning to let go of the need for certainty and absolute answers. The next point refers to striking a balance between managing everything you need to do in terms of taking care of the person with dementia, but also looking after yourself. It's important to grieve in an open and adaptive manner before the person's death, and whether that's with the help of a professional like a psychologist or counsellor, or with a trusted friend or family member. Some of the literature shows that having that support from the same person before and after death is helpful because there's that consistency. And lastly, try and foster as much adaptation and proactivity as possible. And finally, I'd like to thank the entire Fronty team and all the inspiring participants and their carers, because our work would not be possible without them. Thank you.
Thank you so much for that excellent talk, Morale. We had a comment from the audience that you managed to capture the heartbreak of caring for someone with FTD, so thank you for that. We do have a question about online support groups, but this is going to be covered by another talk coming up very soon. So in the essence of time, we might keep going with the next thing. So thank you very much.
Thank you. Let's bring that piece of paper.
All right. Hi, everyone.
Hi, my name's Mel. I'm married to Tony, who's 59. Approximately 6 years ago, Tony was diagnosed with a familial dominant genetic mutation variant of FTD. It runs through his father's side of the family and has affected quite a few members of that branch of the family tree. Also, one of his siblings is also recently diagnosed. Tony's condition presents a bit differently to the usual FTD. His behavioural symptoms are very benign. They are more anxiety-based behavioural symptoms, and his is more Alzheimer's type symptoms, although it is a genetically proven FTD. So he has very poor short-term memory, and our conversations are very repetitive. We live on a day-to-day basis of just constant questioning of where we're going, who we're seeing, have we seen, of just constant questioning of where we're going, who we're seeing, have we seen them before, of just constant questioning of where we're going, who we're seeing, have we seen them before, have I been here before, do I know them, what's the time? And 5 minutes later, I'll have the same round of questioning again.
Hi, everyone. We've had some difficulties with Mel's video, so we might come back to that in a second. What I'm going to do is I'm going to hand over to Morel to introduce Rebecca Ahmed, who's going to talk about research.
Thanks, Wendy. So we're going to have Associate Professor Rebecca Ahmed talk next. Rebecca is an Associate Professor and Specialist Neurologist with expertise in frontotemporal dementia and associated disorders. She is the Director of the Memory and Cognition Clinic at the Royal Prince Alfred Hospital in Sydney, and also conducts research with the Frontier Group in Sydney. Her primary research interest is in eating and metabolic abnormalities in frontotemporal dementia, and today she's going to tell us a little bit about future research and clinical trials. Thanks, Rebecca.
Great, thanks, Mirelle. Can you put me in presenter mode? Great, so hopefully everybody can see my slides. So really what I wanted to do today was give you an overview of what research is going on in frontotemporal dementia, and then also talk about some really exciting clinical trials that are starting in Australia. Some of them have started and some of them are going to start later this year. So I'm part of the Frontier Group at the Brain and Mind Centre, and the Frontier Group really started in 2008 when John Hodges moved from Cambridge to Sydney, and he's since retired, but there's still a lot of fantastic research going on. And more recently, we moved to the University of Sydney and Royal Prince Alfred Hospital. So really what Frontier has focused on is all forms of frontotemporal dementia, but we've also focused on the overlap between frontotemporal dementia and motor neurone disease. And we focused on a number of aspects, including the genetic aspects, clinical aspects, and also the underlying pathology. And many of you have come to Frontier as part of our research program, and for that, we're extremely grateful. So some of the research projects that we've got going at Frontier look at all aspects of frontotemporal dementia. So we've looked at cognitive aspects, including memory, my particular area of research, which looks at metabolic and eating abnormalities, social cognition, the overlap in between FTD and psychiatric symptoms. language problems, neuroimaging overlap, and also the overlap with motor neurone disease and other Parkinson's disease symptoms. And what we've really tried to do is get to the bottom of what causes FTD and how we can mark disease progression and eventually try and help come up with a cure for this devastating condition. We've also had a major arm of our research looking at the impact of FTD on carers and patients and quality of life. And more recently, we're involved in a number of clinical trials, which I'll go through with you. In terms of what we've really looked at is we've looked at these key factors and what brain structures control these factors. And that has really helped in the development of potential treatment options, because if we know what the underlying changes in the brain are that are causing these symptoms of FTD, then we can really look at treatments that may be able to target these changes. And one of the major areas that we always get asked about is what is the survival like in FTD, and what can people do to try and prolong survival and slow the progression of the disease. And more recently, we've looked at our survival data in all the patients who've come through with FTD. And these are the results of the patients that had behavioural variant FTD. And essentially, what we found is most patients have a median survival of about 10.8 years. And without dependence, that's 8.9 years. And patients with a shorter survival tend to have a shorter disease duration. They have poorer visuospatial function. So that involves knowing where things are in space. They have a higher burden of behavioural symptoms, shorter disease duration at diagnosis, and an older age, and also atrophy in particular brain areas. And more recently, what we've tried to do is come up with profiles that can help us predict what someone's survival with FTD is going to be like. So that can give knowledge to carers and families, how long a patient's got, and what factors they may be able to change to try and slow the progression. So what we found is that symptoms such as apathy, patients who have early motor symptoms, so those are patients who develop motor neurone disease, who have changes in their lipid profile, so actually decreased cholesterol levels, actually have a poorer survival compared to those patients that have, for example, a change in eating behaviour. So my research has looked a lot at how changes in eating behaviour can affect progression. And actually a lot of the eating changes that patients get, so eating the sweet preference, fatty foods, are actually a benefit because their metabolic rate increases and it helps them to maintain their body mass index. So at the moment, we're advising carers not to try and limit how much a patient eats, but to let them eat as much as they want within limits. So that's really where the research is heading at the moment in terms of coming up with profiles so we can predict survival. In terms of the treatment options, at the moment, we've been limited. So there have been kind of 3 basic treatment options that are very much related to symptom management. So we've used a lot atypical antipsychotics, managing carer burden, and selective serotonin reuptake inhibitors. And if you compare this to, for example, Alzheimer's disease, so this is a slide showing all the different treatment options that have been trialled in Alzheimer's disease, you can see that the FTD world is quite far behind the Alzheimer's disease world in terms of trying different drugs to slow the progression and potentially cure patients. And really what's happened probably in the last 2 years is that groups from around the world have really come together to try and come up with specific drug treatments that we can use to try and treat FTD. And what's been developed is the FTD Prevention Initiative, which involves sites in Australia, the US and Europe, looking at trialling different drugs to try and slow the progression of FTD. And one part of this is particularly looking at patients who have specific gene mutations. So a lot of you listening may be part of the DINAD study, which is looking at patients' families, so people who are pre-symptomatic with any of these FTD mutations and looking at the progression of the disease. And leading on from this has been the development of a number of clinical trials in FTD. One of the problems that we have with clinical trials in FTD is knowing where to specifically target the treatment. So do we start when patients are asymptomatic? And for that, we would be limiting our trials to people who have known genetic mutations. Or do we target them when patients are symptomatic or just symptomatic in the middle? And with drug trials, are we looking at things that prevent the onset of the disease, or do they modify the underlying disease, or do we look at symptomatic therapies? So I'm really excited now to tell you about 4 clinical trials that are now currently available in Australia. And at the end of the talk, I'll have an information slide that will have the contact details you can contact if you're interested in being part of any of these trials. So when we talk about clinical trials, what do we mean? Well, a clinical trial is a trial that aims to evaluate the effect of an intervention on a disease. It helps us better understand the disease and the potential treatment options. Many trials can be of benefit to the participant, but they may not directly benefit the participant, but may be able to provide more information on the disease, guide us in terms of future treatment options, and they also may help the next generation. So when we talk about different clinical trials, there are different phases of clinical trials. And this is a way that we learn whether drugs are safe and what effect they might have on diseases. So when we talk about phase 1 trials, these are the first kind of trials where they trial a drug in humans. And the purpose of these trials is to evaluate the study drug in terms of safety and identify any side effects. And usually phase 1 trials are in a small number of patients, and it's trialing the drug for the first time. Phase 2 trials, they trial it in a much larger group to determine if it's actually effective in changing the progression of the disease and to provide further information on the safety of the drug. And phase 3 trials are really when the drugs are trialed in large groups to confirm that it's effective, monitor for side effects, and to compare it to other treatments or placebo where we don't give a treatment to see if it actually has an effect. And phase 4 trials are where drugs are approved by the FDA, or in Australia, the TGA, and after phase 4 trials, they're made available to the public for general use. So what I'm going to go through now is the first trial. So the first trial is a phase 1 trial. So this study is by a company called Piguet, which is based in New York City, but we have a site for this trial in Australia. And this trial is using a form of therapy that we call gene therapy. And essentially, this is a new treatment that aims to modify a person's underlying genetic makeup. So this trial is specifically for patients who have a progranulin mutation. And I think Clement covered that in his talk. And essentially what gene therapy does is it insert, when you've got an abnormality in one of your genes, we would give gene therapy to insert a healthy copy of a gene or genetic material into a patient's cell to compensate for the bad gene or the mutated gene. And it allows the body to produce a beneficial protein that makes up for one of the faulty genes or the product of that gene that's otherwise not produced. And there are many gene therapy approaches, but Piguet is using a vector, so a carrier for the gene called AAV. And essentially this is a slide to show what we do in gene therapy. So what we do is that we attach a new gene to a vector, which is a deactivated virus, so it can't be harmful to you. Then we inject it into the body, and then essentially it gets carried to the nucleus, which is kind of the epicenter of all our cells, and then we insert the healthy copy of the DNA into the cell, and then that produces the normal protein, which the faulty DNA was not able to do. And the study that's in Australia is called the Proclaim study, and this is running in Sydney. It's probably going to start in about December. And essentially what we're looking for is patients who have a known granulin mutation, who are aged between the age of 30 to 80 years, and they have to be in the symptomatic disease stage, so early FTD, and be on stable background medications. And it will be trialled in a very small number of patients. The good thing about this trial is it's a one-off treatment, so you don't need to come back week after week for any infusions or things like that. And what happens is that you have a lumbar puncture, which is a very simple procedure that we do all the time as neurologists, and we inject this genetic material, and then you undergo monitoring for the next 5 years to see if it's safe and tolerable and whether it has any underlying effects on disease progression. The second trial that I wanted to talk about is also specifically for patients who have a progranulin or granulin mutation, and this is by a different company called Elector. The difference about this trial is it's not only in symptomatic patients with a granulin mutation, but it's also in patients with pre-symptomatic disease. So if you know in your family that you have an underlying granulin mutation, then you may wish to find out more about this study. And essentially what they're doing in this study is giving patients an infusion of what we call a monoclonal antibody to try and increase the protein levels of granulin, which we know is low in patients who have the granulin mutation. And essentially it's just started in both Sydney and Melbourne. And essentially it's a phase 3 study, so it's a bit further on than the previous study, which is a phase 1 study. And it's looking for patients that have a progranulin gene mutation. The key inclusion criteria for this study is that you have to have a granulin mutation. You can be either symptomatic or pre-symptomatic and have either behavioural variant frontotemporal dementia or progressive non-fluent aphasia. You need to have someone who will come along for the study visits with you, and then of course we get informed consent. We know that in all of these studies, there are exclusion criteria where it's not safe to give these drugs. And the main things are if people have uncontrolled hypertension, diabetes, or thyroid disease. And if you're planning to have a family or might be pregnant or breastfeeding, we wouldn't put you in a trial at that stage. We would wait until you had stopped having your children or weren't planning to have your children for a number of years. And the main outcomes that they're looking for in this study is we're using a number of rating scales that we use standardly in dementia trials to see if there is an effect on the disease progression. And we're also looking at what we call biomarkers, so they're signs of what's going on in terms of the underlying disease, and that involves both blood biomarkers and CSF biomarkers, where we would do a lumbar puncture. This trial is a bit involves coming every 4 weeks for an infusion for 12 months if you have symptomatic FTD, and 2 years if you're in the pre-symptomatic stage and just have an underlying mutation. The third trial that I wanted to talk to you about is actually a trial that's had its beginnings in Melbourne. Professor Terry O'Brien has really led this trial, and essentially it's using a drug called sodium selenate, which is very safe to take. And they've already run this trial in patients with Alzheimer's disease, and now they're looking at doing it in patients with behavioural variant FTD, and they've also done a phase 1 trial in patients with behavioural variant FTD. And essentially what sodium selenate aims to do is reduce the level of tau, which we know is one of the proteins that causes FTD and is deposited in the brain. And these are the results for the phase 1 trial that they've already done, where they gave this drug to 12 patients for 12 months. And what they found was that the drug was safe and well tolerated. the impressive thing is that by giving this drug, what they found was that NewCog is a measure that we use to measure cognitive change. What they found was that there was no change in cognitive or behavioural symptoms, and they felt that there was a slowing of brain degeneration in most patients. And that first phase 1 trial is due to finish in December of this year. But pleasingly, there is a phase 2 trial which is starting comparing the drug sodium selenate or placebo, and the aim is to recruit 120 patients with behavioural variant FTD between Melbourne and Sydney over 4 years. So these patients don't need to have an underlying genetic mutation, they just need to have a diagnosis of behavioural variant FTD, and we'll be looking at outcomes including brain changes on MRI, cognitive symptoms, behavioural symptoms, levels of the tau protein through both blood and CSF, and whether the drug is safe and tolerable. And that study is due to begin in December or early 2021. So the key inclusion criteria for this study is that you have to be aged over 35 years. You have to have a diagnosis of behavioural variant FTD, and you have to be able to undergo a lumbar puncture and a brain scan, and you have to be living in the community. So unfortunately, you can't be in a nursing home facility, and someone who's willing to come along with you for the appointments. There are, of course, without any trial exclusion criteria, and that includes if someone may have substance abuse disorders, if they've got a known sensitivity to any of the selenium, which is the drug we're going to give, and if they have another cause of the behavioural or cognitive symptoms other than behavioural variant FTD, and if they have a history of familial Alzheimer's disease. Sometimes we see patients who have a family history of Alzheimer's disease and then have a diagnosis of FTD, and we're not sure whether the underlying disease is Alzheimer's disease or FTD. The other thing that we know will exclude patients is if we suspect that they don't have underlying tau pathology in the brain, and we know that's the case in patients who have a genetic mutation with the C9orf72 mutation or the granulin mutation. So this study is really targeted at people who don't have a family history of FTD, but are what we would call sporadic behavioural variant FTD. And they're the other exclusion criteria, which is just other uncontrolled medical conditions. Then the final trial, so we've had a phase 1 trial, we've had a phase 3 trial and a phase 2 trial, and then the final trial that I wanted to talk to you about is a phase 4 trial, which we're running out of Sydney. And this is very much a trial to look at the symptomatic management of FTD. So it won't necessarily change the underlying pathology or the disease progression, but it aims to help manage the underlying symptoms of FTD. And Olivier, who spoke earlier, is the principal investigator for this trial. And essentially what we're aiming to do is use oxytocin, which is sometimes known as the love hormone. And what we know is that oxytocin is a drug that modulates our emotional response, so how we respond to things. So what we know is that oxytocin can improve our social behaviour, improve our emotional recognition, and improve our trust and interaction with other people. And those are all of the characteristics that we see changed in patients with FTD. So what this drug is really aiming to do is change many of the behavioural changes, that lack of empathy, those emotional changes, to see if it can improve these symptoms in patients with FTD and also reduce carer burden. And so this trial is good in the sense that it's a very short trial. So it only lasts for 1 month. And essentially what it involves is that patients will come in to be screened, and then they'll be divided into half of the patients getting oxytocin and the other half getting placebo. And the oxytocin is just administered as a nasal spray, and when you first come in, you're shown how to do it, and then you can go home and you do the nasal sprays at home with the help of your carer. And then you have phone contact with the researchers and a number of one follow-up visit where we check a number of tests of emotion processing and also check blood for oxytocin levels. And then when you get to the 2-week period, what we do is swap the groups over. So the group that didn't get the oxytocin, will now get the oxytocin, and the group that got the oxytocin will then go on to placebo, but you will not know which drug that you're getting. And it's really looking at the effect that oxytocin has on patients with FTD and their emotion processing. And for this study, we're looking at doing it in both patients with behavioural variant FTD and also the language forms of FTD to see if it helps with emotion processing and also in reducing carer burden. And so these are the outcomes that we're measuring. So it's looking at social cognition and behavioural symptoms, and then also looking at carer questionnaires and carer burden, and also looking at blood levels of oxytocin. And so these are the contacts for the trials if you would like to be involved in them. So in Sydney, we've got running the Proclaim study. So that was the study we're using the gene therapy for patients with granulin mutations. We've also got the Elector study, which is again for patients with granulin mutations. The Selenate study, which is for patients with behavioural variant FTD. You do not need to have a genetic mutation. And also the oxytocin study, which is for patients with both behavioural variant FTD and the language forms of FTD. And if you email Cassandra, she'll be able to answer any questions that you've got. In Melbourne, they also have the Elector study, which is running through Amy Brodman at the Eastern Cognitive Disorders Clinic. And then they've also got the Selenate trial, which is being run by Professor Terry O'Brien, and there are a number of sites throughout Melbourne. But if you contact Lucy on her email, she'll be able to provide you with further details. And pleasingly, the Elector study for patients with granulin mutations is also running out of Perth with Dr. Carolyn Orr, and her study coordinator is Susan Walters, who's happy to be contacted if you might be interested in those studies. Obviously, if you're not in Sydney, Melbourne or Perth, you could come to one of these sites to be part of the trial when the borders are open. So the major message I wanted to have is that I think 2020, if you had asked me in 2019, were there any treatment trials for FTD, I would have said no, but this year we've got 4 trials in the 1 year, and I know that there's probably another 2 that are on the horizon for FTD next year. So trials in FTD are really on the go ahead, and so hopefully we can eventually find a cure for this devastating disease. So I'm happy to take any questions. Thank you.
Hi, Rebecca. Thank you so much for your talk. That was great. We did have one question about what the best way to get involved in these trials was, but you did answer that at the end there. So we didn't have any other questions, and we might hand back to Morel, who can introduce our next video.
Great, thank you.
Thanks, Rebecca, for that talk. So we're going to try and play our second last carer video, Mel, and fingers crossed it actually works this time. So Mel is in her 50s and she cares for her husband, Tony, who was diagnosed with behavioural variant FTD in 2014. Mel's been caring for Tony at home ever since. And in her video today, Mel reflects on her journey as a caregiver, and she touches on the experience of grief in particular and what it was like for her from the moment of diagnosis.
Hi, my name's Mel. I'm married to Tony, who's 59. Approximately 6 years ago, Tony was diagnosed with a familial dominant genetic mutation variant of FTD. It runs through his father's side of the family and has affected quite a few members of that branch of the family tree. Also, one of his siblings is also recently diagnosed. Tony's condition presents a bit differently to the usual FTD. His behavioural symptoms are very benign. They are more anxiety-based behavioural symptoms, and his is more Alzheimer's type symptoms, although it is a genetically proven FTD. So he has very poor short-term memory, and our conversations are very repetitive. We live on a day-to-day basis of just constant questioning of where we're going, who we're seeing, have we seen them before, have I been here before, do I know them, what's the time, and 5 minutes later I'll have the same round of questioning again. He's very high functioning in many other ways. He can still drive. He passes his annual driving test very well. And so it's just that short-term memory that is really the problem. He can forget after dinner that he's even eaten and make himself quite a large sandwich after a large meal. So we have a few sort of little delicate issues around that we're trying to deal with. I find that it's very hard not to not be critical when I'm reminding him that he's eaten. You know, you've got to be so delicate in how you approach them, because you know, it's not their fault. They have dementia. It's not their fault that they're exhibiting these symptoms. So it's hard to find the diplomatic way of saying what you need to say without, you know, hurting their feelings. And sometimes you have a lot of guilt as a carer associated with that, because, you know, as a carer you get frustrated, you get angry, you get annoyed. And, you know, they're your feelings. You're allowed to feel those ways, but then you feel guilty that you've maybe put that onto them somehow. So I certainly found as a wife that, you know, I struggled with that for quite a long time, and I went and got some counselling with a grief counsellor who was so helpful in helping me realise that that's okay to feel those feelings. You know, I can't change my situation, and those feelings are perfectly normal. But I just had to find other ways of maybe reacting to them. So try and wait until I'm alone to want to scream or you know, get annoyed, and at that very moment just try and take a breath and talk to Tony. And we're very lucky that we have very open lines of communication with each other, and I found it very important to talk to Tony about, you know, he is the one living with dementia, but it's my journey as well, and I'm also there. That's so important that you do talk to each other and have a good inner circle of friends, a group of friends, not just friends that you can chat to, but friends that you can say anything to. You know, there are some things that sometimes you just want to say things that you couldn't say to somebody that doesn't know you well and that isn't forgiving, if that makes sense. You know, I'm fortunate I have my children. I have, you know, a couple of very close friends, and I have my sister-in-law that I can say anything to and not be judged badly for. You know, it is very important as a carer. So out of all of this, I think the best advice I can give you is to talk, to you know, get involved in groups that are associated with dementia, a carer support group, and just find the resources out there through NDIS, Dementia Australia, and Facebook groups. You know, they're all there, and you will find the one that connects with you the best. So good luck with your journey. We're all in it, and we're all living it, and the feelings are real.
Hi everyone. I'd just like to thank Rebecca so much for her excellent talk. So now myself and Dana Fail are just going to talk about practical supports for people living with FTD. So this won't take too long, and then we've just got one more video at the end as well. So just hold on 1 second while I get the slides up. Okay, now I'm hoping everyone can see the slides and also hear me and see me clearly. What we're going to talk about just is practical supports. And the first one is FTD carer support groups. So a number of you in the audience may already be in an FTD carer support group. And there was also a question about support groups specifically for language variants, which Camille, our speech path, is going to answer. So in Australia at the moment, the FTD specific support groups are run by Dementia Australia, and they're run in 3 states, in Tasmania, Victoria and New South Wales, and there's plans for support groups across the whole of Australia as well. And so they were set up in recognition that caring for someone with FTD has very unique challenges and is quite different from caring for someone with Alzheimer's disease. And that's mainly because of the very significant differences in behaviour, and also that it's a young onset dementia, so people are caring for someone in midlife. It's been shown in a lot of research that caring for someone with FTD, there's a much greater carer burden than there is in other types of dementias. And carer support groups work by thinking that everyone is in the same boat, that people that are experiencing and caring for someone with FTD feel that they get it and they feel understood when they attend. Okay. So what are the goals of carer support groups? So there's the group therapeutic effect, and for people that have been participants in support groups, probably they learn the most from the other people actually in the support groups that have been caring. And so people from the very beginning of their journey right through to the very end can help and support the younger or the more inexperienced carers along their journey. And it's that mutual support and understanding which is thought to be so effective. It's thought to also build capacity and strength, and also educate people about the different changes in FTD and what to expect next. I'm now going to get Dana Failed just to talk about some of the practical agencies and supports that are required for people with FTD. So I'll just hand across to her now.
Hello again. The National Dementia Helpline, or Dementia Australia, is a support that we at the Royal Melbourne utilise quite a lot. The phone number is up there, and it's just a generalised phone number, and that is an intake phone number for all the supports that they offer, which is really a one-stop shop to be linked into groups, counselling, support. Their website, which is down the bottom, has got a really amazing amount of information that's very, very easy to find, very, very easy to locate, and really informative, and in language that's very, very easy to understand. The other thing that they do is if the person that you are caring for is under 65 and eligible for an NDIS package, they can help you through that sort of service system of how to access supports for those that still find NDIS a bit tricky to navigate. Dementia Support Australia is previously known as DBMAS, or Dementia Behaviour Management Advisory Service, although it is still part of their service. It's run by Hammond Care. Anyone with a diagnosis of dementia or a suspected diagnosis of dementia is eligible for their service. They are Australia-wide, and particularly they have a focus on people in remote areas. They can they look more at capacity building and management plans for people that are struggling with symptoms of dementia. They can do face-to-face assessments, video conferencing, phone assessments, and they can also work with health professionals in residential care, or sometimes in hospital units, to come out and put together a management plan for someone that might be struggling. Their phone number's there and their website is there. They do say that they'll have a 7-day response, so if it's very, very urgent, they might provide a 24-hour response. Something that's not so urgent, they may take up to 7 days, but they're a very good support to know about for healthcare professionals and for families. The NDIS, I'm going to try and do this quickly. It's not really possible, but I'm going to try. The National Disability Insurance Scheme is what used to be the Department of Disability Services, and it is for people who are under 65 years old with a disability, and dementia is included under that. The website is up there, and it's quite a self-explanatory website. But generally my experience is if you can get a good support letter from your health professional, like an OT or your doctor or a social worker, you generally will be able to access a decent plan. And that can include anything. If you're creative enough, you can sort of try and get a whole lot of things in your plan, including funding to go to the gym, funding for home modifications, general carer support, general personal care support, transport, carer respite, behaviour support planning, as is written on the slide. My Aged Care is for people over the age of 65. That's when we get an aged care assessment, and that's a one-stop shop through that website there. And that is for services for people over 65. Probably NDIS is probably got more money in it now, but My Aged Care is unfortunately the only way we can do if your diagnosis is occurs after the age of 65. And public mental health services, allied health professionals, GPs, psychiatrists, neurologists, geriatricians, nursing, dementia specialists. I think Wendy's written gold, which means use those services if you can. And if you're desperate, or if it's on a weekend, or if you can't access anyone, there is no shame in calling 000 or turning up to a public emergency department to get some support with if you can't access it elsewhere. Can't see that slide. This is a slide, and you might be able to get access to it, which I can't even see what it says, but I think it's a framework of where to go and what to do according to how old you are, I think. Here are some other supports: the Australian Frontotemporal Dementia Association, American FTD Association, and the Rare Dementia Support website, which will have some more information for you that you might find useful. Wendy, do you want to talk about these forums?
Yeah. Hi all. So look, really these are just chat forums for people with FTD, and all of this information will be on the website. Other supports, so ECDC, Eastern Cognitive Disorders Clinic, if you live in Victoria. There's a variety of different memory clinics across Australia that support people living with FTD, and there's a list of them on different websites, particularly for people that have language variant dementias such as semantic dementia and PNFA. Some of the aphasia associations and speech pathologists can be extremely useful, and also obviously Frontier has done a huge amount of research in Sydney at the Brain and Mind Centre. So this is just a quote from Heather, who's one of the carers in the Tasmanian group, and I'll read this quote out now. So this is about her experience of attending an FTD carer support group. As soon as he was diagnosed, I got in touch with Dementia Tasmania. The FTD Carers Support Group has been a lifeline for me. To share with others who understand and to have that quality time is a blessing. I draw strength from others' stories. Several are dealing with far more than I, and with such dignity and willingness. We enjoy the time together. We laugh, cry, relax, and are aware that we're not going through this alone. So I thought that that was probably a nice quote to end on. So look, I'll stop sharing our slides now, and I'll just check if there's any questions.
Hi, Wendy. Thank you so much for that. There's just a couple of questions here that you might be able to briefly answer. One of the questions was, if you're caring for someone with FTD and they're still capable of showering, toileting, making breakfast and lunch, but you feel like you're in need of a break, what would you suggest since an aged care facility doesn't feel appropriate?
Yeah, sure. Look, I might get Diana, who's our social worker, to answer that. Just one second.
I think the best way to manage that, if you just wanted a one-off break, would potentially ask a friend or a family member. If that's not going to work, you could get informal services. There are a whole lot of services online, apart from the ones that we spoke about, where you can just get one-off help. There's a website called Mabel, which sort of works like Airtasker, except it's for carers, and you can see, and it has people that provide care, and you can see all their qualifications, male, female, what languages they speak, and you could access intermittent care through there. If you wanted something more ongoing, depending on the age of the person that you're providing care for, I would start looking at perhaps getting an NDIS package or an aged care package to get some more planned and structured care to give you regular breaks. I hope that answered the question.
Great, thank you for that, Dana. And there's just one more question. So someone would like to know why residential facilities aren't generally suitable for people living with FTD. So is this due to staffing levels, training, support, or unsuitable environment? And they'd just like a little bit more information and direction on that.
Yeah, I think Sam Loy mentioned that in her talk. I think perhaps what she meant was that generally with frontotemporal dementia, the person with dementia can be younger. Generally, you have to be over 65 to access an aged care residential service. So sometimes people under 65 may struggle a bit more in a aged care facility because there's no one of their age. Perhaps the activities aren't structured around what their needs are. But I think with the onset of NDIS now, if you have an NDIS package, you can still go into permanent care, but keep your package, which means that you can still have NDIS workers going in to see the person that you're caring for and doing some more age-appropriate activities with them, or taking them out and still doing things that they may enjoy. And there are now starting to be some aged care facilities which cater towards the younger people, not as many as I'd like. But there is becoming more awareness in the community of a need for residential care for people who aren't, who are reasonably young.
Great, thank you, Dana. That's all for now.
Okay, just pop you back to Wendy, who wants to say some final thank yous.
Thanks, everyone. So we're now at the end of the World FTD United Marathon for the Australian leg. So before we finish, I'd just like to say a couple of thank yous, and then we'll be playing a carer video after that, and then Tracy Wardle will be saying goodbye and thank you to everyone. So first of all, I'd like to say an enormous thank you to Tracy Wardle, who's part of World FTD United and the AFTDA, for having the dream and inspiration to create the Australian leg, and for supporting us all, both in Sydney and Melbourne teams, into making this happen, as well as Margie Beasley, who's part of World FTD United, AFTDA and Dementia Australia, who's also been integral and is a Dementia Australia Tasmania support group leader. So thank you so much to both of them. I'd like to thank so much to all the speakers today as well. So beginning with Olivier, with Clement, with Dennis and Dharma, with Camille, with Dana and Sam and Morel and Rebecca, and they've all been absolutely wonderful. And I'd also like to thank so much our wonderful tech team, which has concluded Siam, George, Sam, Jess and Claire, and particularly Claire for asking a lot of the questions, and Morel and Sam and Jess, the team in Sydney, have been absolutely fantastic, and we've needed all the support we can get with tech, as you've been able to see today. The final thing is I would like to say thank you so much to our families and carers. Everything we do today is for you, and we've learnt everything we know from you, and you've been an absolute inspiration to us you know, throughout our whole journey, and we're just so grateful for everything that you do. So thank you. And now I'm just going to introduce Desi, which is the last video. So Desi lives with her husband Ron and has behavioural variant FTD. And Ron was diagnosed in 2016, and Desi has been looking and caring for him at home ever since. So in her video, Desi talks about what's in her carer toolkit and reflects on her evolving relationship with her husband and how there's always hope for connection. So I'd like to welcome Desi, and then Tracy will be speaking to you after that. Thank you to all for having us.
Greetings, my name is Desiree. I'm 69 years old and a full-time carer for my husband Ron, also age 69, who was diagnosed with behavioural variant frontotemporal dementia in March 2016. He is mobile but has few meaningful words, is incontinent and needs assistance with all activities of daily living. We live on Lake Macquarie with a small parkland reserve between us and the lake. It is a familiar, safe environment for Ron, who wanders out frequently, but never strays far from home. The surrounding neighbours are aware of Ron's limitations and they watch out for him. We have 2 sons and their families within 30 minutes drive, and 2 daughters and their families interstate. Ron used to attend a day respite centre 5 days each week, but COVID restrictions imposed in March forced its closure, and I have had him at home 24/7 since. The key challenges I face include keeping Ron mobile and motivated, managing his incontinence, and having the energy to attend to all his daily needs. Ron is quiet with an endearing smile. He is easily agitated but rarely aggressive. As Ron can no longer communicate verbally, I am constantly vigilant to his non-verbal cues and body language in recognising his needs and watching out for any unexpected event which could trigger his agitation. Although he's safe walking around our reserve, Ron would wander off and become easily confused anywhere else. I cannot take him with me to the shops or attend places or events we previously enjoyed. Meals can be challenging as Ron needs his food to be well spaced on his plate and often needs feeding. Ron is unable to initiate or complete the simplest tasks. Early on, I made a decision to embrace this dementia journey and to do the best job I could possibly do. And to this end, I have integrated the following into my essential toolkit. Counselling, so valuable in both recognising and learning how to negotiate the initial and the ongoing grief of this journey. Education, courses, books, online learning. Glean gems from others' stories which may help you. Support services, research what is available to enable you to make wise choices. Connect with Dementia Australia and become part of your local carer support group. Be confident and comfortable with the GP and specialist who are journeying with you. I have used a continence nurse and dementia nurse when needed. Have your finances, power of attorney, advanced care plan, etc. all organised and up to date. Caring others. Involve family and friends as much as possible, and especially the grandchildren. I encourage connection at Ron's emotional level with lots of physical touch, cuddles, plenty of words of reassurance and affirmation. We FaceTime the family regularly and have family photos always present. Forward planning. I have learnt to book respite well in advance. Ron's name is down for permanent residential care should we ever need it. And I have an emergency care kit ready with all the information about contacts and Ron's care in case anything happened to me. Self-care. Prayer and meditation keep me centred. Exercise relieves the stress. Gardening and friends keep me balanced. Journaling helps me reflect on this journey. And I have learnt to ask for help when I'm overwhelmed or fatigued. Finally, couple care. I keep our days simple, predictable, uncomplicated. Long, slow walks twice daily promote togetherness, as well as exercise and stimulation. I build fun into every day. We laugh, dance around, listen to favourite music, operas, theatre, and YouTube makes this all possible. A recent joy was to realise that although Ron has limited, meaningful speech, he is able to join me in singing familiar songs or hymns from his youth without hesitation once I initiate it. And knowing I can still connect with his soul encourages and inspires me to continue this journey. There is always hope. Well, that brings us to the end of the first leg of our 2020 World FTD Marathon. Before I pass the baton to our friends and colleagues in Europe and the UK, there are a number of people who we'd like to thank. First, a huge thank you to all our wonderful presenters, both from neuropsychiatry at the Royal Melbourne Hospital and Frontier Brain and Mind Centre at the University of Sydney. What a fabulous job everyone did. Thanks to the many staff behind the scenes who provided the technical support. It's been a huge challenge and we're enormously grateful for your efforts. All the presenters and support staff generously volunteered their time on a Saturday, not to mention the many hours spent in recent weeks preparing talks, learning how to use the technology and practicing using the technology. Thank you everyone for your time. A very special thank you from all of us to the carers who bravely shared their stories with us today. It's been a really special part of the marathon today. I'd like to thank the AFTD in America for their generous support of our marathon. They provided the go-to webinar platform for us to use, and also the valuable time and energy of some of their fabulous staff. Thanks to the many people throughout Australia and New Zealand who worked hard to promote the event, including the Australian FTD Association. We'd also like to say a special thank you to Enrico Gallagher and Chiara Facciolo, the brilliant Italian designers who donated their time and talent to produce all our fabulous graphics. I'm most grateful to the local organising committee, Margie Beasley in Hobart, Olivier Piguet in Sydney, and Wendy Kelso in Melbourne for the great work they did in putting together the Australian League. I want to make special mention of Wendy Kelso from Royal Melbourne Hospital, who almost single-handedly conquered the mysteries of our online go-to webinar platform and was really the powerhouse of the Australian League. Thank you so much, Wendy, for all the time and the hours you've put into this. A special thank you from me to the wonderful Executive Committee of World FTD United. From the moment the idea of this marathon was born, they have all worked so hard to make it a reality. They are an amazing team of people, all of them dedicated to raising awareness of FTD. Finally, and most importantly, thank you to everyone for being with us on this league. Families living with FTD, carers, clinicians, researchers and support workers, whatever your reason for being with us, wherever you are in the world, thank you for being part of the marathon. Thank you for joining us and for helping to raise awareness of frontotemporal dementia. So it's now time for me to hand over the baton to Hendrik Jan van der Waal, founder and chair of the Dutch FTD organisation. The European leg will start at 10 a.m. Central European Time, which is 6 p.m. Australian Eastern Standard Time. Then at 10 a.m. Eastern American Time, Helen Ann Comstock, the founder of World FTD United, will welcome you to the North, South and Central American leg of the marathon. That'll be some great late night viewing for us in Australia, as it'll be around midnight. It's not too late to register for the other legs of the marathon. Just go to the World FTD United website. You'll find the links to register and the program. Thank you everyone, and for now, goodbye.